I'm Susan Bizarski, the Executive Director of Lupus LA, and we are thrilled to be back together again. This is our first conference in 4 years, so thank you for coming out. The last 4 years have been challenging, to say the least, but the silver lining is that we're moving our content to a digital platform was that we saw our community grow in ways we could not ever expect. So before we start and I introduce our speakers, I just wanted to go through the folder that you have to show everybody. In this folder, you'll have the agenda on the right side, the bios of our speakers. That way, we don't have to read them. So please get familiar with the speakers. They're all incredibly impressive people, and we really appreciate their time here today. All of our speakers will offer a Q&A. For Dr. Wallace, we're going to do his famous lightning round with Q&A. So while he speaks, you can put down a question on these cards inside the folder. We'll collect them, and he'll go through them. All of our speakers are going to take questions after Dr. Wallace. We'll just have a microphone in the room and we'll take Q&A. On the left side is a survey, and we are going to ask that you take a few minutes to fill it out. Your feedback is genuinely important to us. We want you to feel seen and heard, and we understand your challenges. We understand that every patient is different in this community, and if we hear from you, it helps us better serve you. So a lot of our programming is a direct response to your requests and your outreach. So please participate and fill out the survey. Behind that is our patient resource guide. If you don't already follow us, please do. lupusla.org, all over social media. We want to remind everybody that we now have 6 monthly support groups. We have 2 adult support groups, 1 Spanish speaking only, 1 bilingual, 1 young adult group that's for 19 to 35, and we just added a male only group. Each one has a licensed facilitator, and we'd love for you to join them. Last but not least, you received a raffle ticket when you signed in, and those will, there will be 3 prizes that we give away at the end of the day. You must be in the room. So a little bribery for you to stay. We're not above that. And then before we begin, I want to thank our partners, Impact Bio, Parexel, AstraZeneca, and Aurinia. Their support, along with the other several other of our partners, make it possible for us to provide today's conference and all of our educational programs, both digital and in person, at no cost to you, and we appreciate that. Please take a few moments during your break to visit their tables and hear about their work. We're excited about all the new work that they're doing in the lupus space. Okay, so it is my pleasure to introduce our first speaker. He is one of Lupus LA's founders, a world-renowned rheumatologist, and the doctor that answers my emails the fastest, Dr. Daniel Wallace.
Right.
Good.
Yeah. Thank you, Susan. It's a pleasure to have us back in business. What I'm going to do is sort of be what we call translational, which means that I am going to talk about some of the immune features of lupus and how they're translated to the clinical environment. I'm going to talk for about a half hour, and then you are free to fill out the 3x5 cards you have, and then I will sit up here and go through the 3x5 cards and answer all your questions to finish by 10 o'clock so that my dear colleague Andy Reif can go on after me. So I am based at Cedars-Sinai Medical Center, where I now run we have a lupus clinic at Cedars-Sinai that's about a year old that I am the director of. And I also co-direct the fellowship program. So see lupus in one slide. What happens in lupus is that understanding its immunologic context is critical to translational developments and finding new treatments that Dr. Reif is going to talk about. It's complicated, it's multifaceted. So there are multiple genes that cause lupus that we'll get into. And genetic lupus is probably about 25% of all lupus, because if a woman in her 20s has lupus, and she is one of an identical twin, the chance that her twin would develop lupus is 25%. So there's a genetic component. There's also an environmental component, and we'll show some of those, everything from obvious things such as ultraviolet light, but also a whole host of other things in the environment, in combination, create an abnormal immune response where we have T cells and B cells, which are white blood cells, dealing with certain provocative factors called antigens, and dendritic cells, which kill cells, and have an altered immune response, which leads to the formation of antibodies and antibody-antigen complexes or immune complexes, which then circulate and settle in tissue, activate complement, promote inflammation, and attack various organs, and then settle and ultimately produce damage and scarring. And that is lupus in one slide. It's a lot more complicated than that. So to focus on that a little more, we have the genetic predisposition, the environmental factors. We also have hormonal aspects, which we'll get into, and some of the structural, some of the proteins or pro-inflammatory chemicals, or include cytokines, interferon, autoantibodies. And it's been shown that lupus usually tends to evolve over, let's say, a 10-year period, and I'll show you some evidence for that. And where benign autoimmunity sometimes just stops and creates sort of an undifferentiated connective tissue disease where you have some abnormalities, but nothing ever happens much, and to pathogenic autoimmunity, to activation of B cells and T cells, antibodies, production of cytokines and interferons, which are promote inflammation, and then lead to classified lupus, which is responsible for the accrual of tissue damage. So what's happened in lupus over the last few decades is that survival rates have improved, but it remains a chronic disease with a higher than expected mortality rate. Survival rates improved a lot in the 70s, 80s, and 90s with the development of steroids and new antibiotics and new treatments, but the survival of lupus in the last 10, 20 years hasn't really changed. And this is from the Mayo Clinic. The patient survival, basically there's two types of lupus. There's organ-threatening disease and non-organ-threatening disease. Organ-threatening disease being heart, lung, kidney, liver, brain, or bone marrow. That's half of lupus. And non-organ-threatening disease being we call constitutional fatigue, being achy, tired, having some rashes and swollen joints. And that's associated with a fairly normal life expectancy. And we have not made a lot of dents in organ-threatening lupus. We have made some dents in non-organ-threatening lupus. So lupus, even under control with steroids or antimalarials or other drugs, it progresses, and damage indices show that 1/3 of all lupus patients accrue permanent organ damage within 5 years of diagnosis. And it slowly progresses. Even if your SED rate's normal, your CRP is normal, this process is very slowly progressive. And work here from UCLA has shown that, from Ram Singh in the Division of Rheumatology here, shows that it's an underestimated cause of death. If you look at death certificates in the United States, only 10 to 15,000 people a year die from lupus. But if you look at it on a death certificate as a contributing cause, it's much, much more common. And in fact, lupus is the #1 single cause of death among females between the ages of 15 to 24 with chronic inflammatory diseases. It's the 7th leading cause of death for females in that age group, and the 5th leading cause for people of color, especially Black and Hispanics. 1/3 of all lupus patients in the United States are African American. And it's in the top 15 of all leading causes of death of all females between the ages of 10 and 44. So I talked a bit about the genetics of lupus, but there's some very interesting developments. We know, of course, that hereditary components predispose to lupus. About 10 to 12% of lupus patients have an affected first-degree relative with lupus. We talked about the monozygotic twins being 25%, but it's only 1 to 2% among fraternal twins. So there are many different gene products that contribute to lupus susceptibility. And some of these genes I listed on the first slide, and there's some others that I'll show you. But there's a new form of lupus that has just been appreciated in the last 5 to 10 years, and that's called monogenic lupus. Monogenic lupus is where a single gene causes lupus as opposed to 30 different genes. And this makes up 10% of pediatric lupus, and AGS syndrome, COPA syndrome being the most prominent. It makes up about 3% of adult lupus. And this is a very exciting area that at Cedars-Sinai we're looking at as an enriched group for study, because this particular group is, we can make advances in understanding the disease much more easily if we only have to deal with one gene. We know that the monogenic lupus tends to be those who have abnormalities in interferon complement deficiencies or autoimmune bone marrow dysregulation. Then we get to the environment. Gosh, can this cause lupus? Can this diet cause lupus? Can a human environment cause lupus? Can this do that? So there's something called epigenetics. And epigenetic is a mechanism where the gene, where your genetic structure is altered by the environment. And there are 3 mechanisms that do that. One is something called methylation, which is a DNA repair mechanism, and hypo or hypomethylation in T cells. The second is modification of histones, which is part of the cell nucleus, and the other is microRNA or small RNA particles under or overexpression. So what these epigenetic mechanisms do is they result in environmental influence on lupus. For example, there is evidence that air pollution specifically is associated with more hospital admissions among lupus patients in China and in Taiwan and in a Canadian study, and more flares in childhood lupus. We know that a data aggregation of 12 studies, including 3,000 people with lupus, comparing them with 300,000 controls, has shown the statistic association between the occurrence of lupus and smokers. We know that tobacco smoke is bad for lupus. We know that there is evidence now from Harvard at Karen Kostenbader's group that residential exposure to pesticides in an urban population of predominantly African American women is associated with increased lupus risk. And stress or trauma is also associated with alterations in cytokines, T cells, B cells, which is associated with autoimmune disease and flare. And now we're getting into the whole role of the microbiome. And we know that certain methylation-sensitive genes and vitamins can cause demethylation which increases T cell, decreases T cell diversity, which causes altered gene expression in lupus, and the diet can play a role in the disease. So some of the factors associated with lupus include cigarette smoking, oral contraceptives, certain heavy metals such as arsenic and cadmium, air pollution, ultraviolet light, silicon, infections, and certain vaccines such as COVID even are associated with alterations in the expression of inflammatory aspects that are associated with lupus. We know that there's over 70 drugs that can cause lupus and 15,000 cases in the United States of drug-induced lupus. The drugs nearly always, most of them are associated with a specific lupus rash called SCLE, which is subacute cutaneous lupus. And these are associated with drugs that treat blood pressure, such as calcium channel blockers, diuretics, beta blockers, ACE inhibitors. There's an antifungal agent, Lamisil, which is associated with lupus, certain proton pump inhibitors, especially Pepsid or Tagamet, sometimes can be associated with a lupus rash. Some drugs used to treat cancer are associated with triggering cutaneous lupus, ultraviolet radiation from the sun, and cancer is associated with some lupus flares, as is certain types of radiation therapy. And then we get to diet in lupus. There's no diet for lupus that we know of. We think that alfalfa sprouts may be bad, that fish oil may be good, but there's recent evidence that bacteria in your gut activates T cells, which promotes autoimmune activity. And this has been demonstrated in psoriatic arthritis and inflammatory bowel disease. And now a group of people, especially Greg Silverman at NYU and Martin Kriegel, who's now in Germany, suggests that the presence of certain gut bacteria are associated with greater activity in lupus nephritis. Lupus patients have less biologic diversity in their gut. And if you look at stool from lupus patients, they often have something called a leaky gut, which demonstrates the presence of some bacterium which enhances adaptive immune responses. So mice with lupus have an altered ability to repair DNA, which is the hypomethylation, and they can improve when given methylated diets. So it's several years away, but we will have a real anti-inflammatory diet, not the phony ones you see on the internet. Fecal transplants, where you transplant stool pellets, may be useful in selective cases in lupus, and some of the other things that are being looked at are probiotics, prebiotics, and antibiotics. So in the 1990s, the Department of Defense decided to do a unique project. They took all of their new military recruits, and they did a whole bunch of blood on all of them, and they stored their serum in a repository in Oklahoma City, and they took a group of these. There was like 200,000 people, and of the 200,000 people, they did blood on them every year for 15 years. And then they looked at the number of people in this group that got lupus, which was about 300, and they compared it with the other tens of thousands who did not get lupus. And they looked at their antibodies before they developed lupus. How many had anti-DNA? How many had anti-SM? How many had anti-RNP? How many had other autoantibodies? And published in the New England Journal, they were able to show that lupus evolves over a period of 10 to 15 years. And let's say anti-DNA comes towards the end, and anti-SSA may come towards the beginning. So it's an evolution that is very, very interesting of how lupus evolves. And sometimes it stops, it's attenuated. And sometimes it progresses, and it can progress at a rapid pace or at a slower pace. So we have pathogenic autoimmunity, we have normal immunity, and then benign autoimmunity, and influenced by genetic and environmental factors. We have pathogenic autoimmunity, which then leads to clinical illness. We talked about the fact that there's about 75 drugs that can cause lupus. The question is, how does it do it? It's unfortunate that we don't have one mechanism. The mechanisms by which drugs cause lupus are fourfold. Either the drug alters the self molecule, the metabolites or breakdown products of the drug produce immune activation, or they activate lymphocytes, or the metabolites disrupt the ability of T cells to be tolerated. So these are being looked at, but with 4 different mechanisms. It's not simple. There's no one way to do it. So to summarize the immune abnormalities in lupus, there's several. We have T cells, which are white blood cells. We have suppressor cells acting as helper cells, which they shouldn't. They're giving wrong signals. They're working with cytokines or interleukins and causing dysfunction. They're producing blebs on dying cells that one becomes sensitive or allergic to. They promote the proliferation of B cells, which then form ANA and other antibodies. They cause defects in immune tolerance. There's innate and adaptive immunity. Innate being what you were born with, and adaptive what is adapted, evolved. And then we have netosis, or neutrophils, or white blood cells, and their breakdown products producing inflammation. Or the mitochondria, which is part of your cell. You used to be told it was the mighty powerhouse of the cell, the energy part of the cell, where its dysfunction produces DNA damage, mitophagy, and reactive oxygen. So some of the newer insights into lupus is that David Pizetsky at Duke has proposed more recently that there's really 2 types of lupus. There is type 1 and type 2. Type 1 is the standard one that we all know, where you're inflamed, where you have rashes, where you have swollen joints, where it's obvious. And your blood tests, you have high sed rate, high CRP, lots of antibodies, and it's treated with the usual anti-inflammatory. Then there's type 2, which are very controversial and harder to treat, where you're tired, you're achy, you can't think clearly, you don't sleep well, you're depressed, you're anxious, you can have brain fog. And these people have normal sed rates, have normal CRPs. They have lupus because they have the antibodies, but we don't really understand what's going on with them. It could be something to do with cytokines, it could be some circulating biomarkers, but there's no good biomarkers that are available. And these individuals don't respond to steroids. They don't respond to a lot of the drugs we use. And the third problem is that in addition to having obvious disease or just symptoms based on certain chemicals released in lupus patients, a lot of these people are diabetics or hypertensive, or they're depressed, or they have other disorders that are comorbidities that are confounding, determining what's really lupus and what isn't. And so there's a lot of work being done. We're working with some Pizetsky's group and some other people to try to do something called RNA-seq, RNA sequencing, where we can find out what the biochemical makeup is in this group. So this is a new hot area that's only was first proposed in 2019. And this is the RNA-based precision medicine, where Peter Lipsky, who was head of rheumatology at the NIAMS at the NIH for many years, is proposed that there are 9 different subtypes of lupus with a particular molecular signature, and they're all treated a little differently. And then the other area that we're looking at is that's evolving is with the central nervous system. So there's three parts of the central nervous system. There's three parts of the nervous system in lupus. There's the central nervous system, the autonomic nervous system, and the peripheral nervous system. Well, the central nervous system is your brain and spinal cord, and it can become inflamed and form vasculitis, usually in children with lupus or in early lupus. There's also peripheral nervous system, which is the ability to move your arms and legs and feel things. And then there's this part that we don't really understand called the autonomic nervous system. The autonomic nervous system controls your pulse and blood pressure and does so by opening and closing blood vessels. So it's sort of like what Raynaud's is, where you, when it's cold, you don't get enough blood flow to the hands. When it's really warm, you get too much blood flow to the hands. So we call this Raynaud's of the brain, or vasomotor instability. When you get too much flow to the brain, you get a headache. When you don't get enough blood flow to the brain, you get a fog. And in these individuals, sed-rate CRPs are rarely abnormal, and patients do not respond to steroids or anti-inflammatory regimens. And this dysautonomia is present in the majority of lupus patients to varying degrees. Recent imaging with brain scanning, whether a PET scan, a SPECT scan, or a functional MRI, has shown that there's something in the watershed region, which is where, let's say, the temporal lobe meets the parietal lobe, that regional alterations in capillary flow leads to this poor circulation and causes a lot of these symptoms, and they come and go. And there's some evidence with looking at small fiber neuropathies and sweat gland pathology that we can also characterize this. So when we're talking about dysautonomia and lupus, we have Raynaud's, where fingers turn different colors in cold weather. We have the headache, where it's from the dilation. We have cognitive impairment from constriction. We have sort of a lace-like modeling checkerboard appearance of the skin with redness of the in different areas that comes and goes. It's also associated with mitral valve prolapse. It's also associated with symptoms of numbness, burning, and tingling, where if there's a lot of pressure on a nerve, you develop burning and tingling, and it activates certain sensors of nerve inflammation. And this is an area that is present in the majority of lupus patients from one type of another. And the reason why I'm telling you about all this is there's been some dramatic new developments in this area. Betty Diamond, who's on Long Island and is one of the best lupus investigators in the world, has discovered some anti-double-stranded DNA antibodies that are associated with learning, thinking, and memory, and prolonged stimulation can lead to calcium flux and death. And this, along with the vasomotor instability, plays a role. And these antibodies are present in about a third of all lupus patients. And there's part of the spinal cord called microglia, which were used to be thought to be inert, but they make cytokines in the central nervous system that you cannot measure in the blood that cause inflammation and raise certain cytokines. So I think Andy's going to talk about some of the newer treatments for lupus, but some of the targeted therapies in lupus are sort of characterized by category. There are agents that block T cells, such as Orencia, which is on the market. There are agents that block B cells, such as Benlysta, that most of you have heard of, or rituximab. There are agents that block complement, usually for more acute inflammatory processes in really sick patients, such as Ultomiris or eculizumab. There are agents that block cytokines, such as tocilizumab, agents that block tumor necrosis factor, and agents that promote certain cytokines such as interleukin-2. There are agents that block the innate immune system that we're born with by dealing with plasmacytic dendritic cells or NETs or and cytokines and toll-like receptors. There are agents that tolerize molecules so you don't become sensitive or make antibodies to it. And more recently, there's a lot of cell surface receptor activation inhibition. Some of you may have been on Rinvoq or Xeljanz or baricitinib, which are pills that have an effect on inhibiting cell surface activation. And then we get to lupus nephritis. So there's 200,000 people in the United States with lupus nephritis, and 80,000 of them have involvement in the kidney, about 40%. About 20% of them have serious involvement, and we don't have really any good biomarkers for kidney. It used to be that the glomerulus, which was part of the kidney, was responsible for most of the dysfunction in the disease, but now we also know that the interstitium is also important. And we have new imaging studies that are able to pick up some of these abnormality. And we know that blood flow to the kidney is very important. And there are groups that are looking at different biomarkers. It may be, hopefully, that lupus biopsies, which require hospitalization, will be obsolete in the next few years. And just by certain imaging, we'll be able to characterize what's going on in your kidney. There's also, in addition to, there's two types of treatments that are different than drug treatments. One is stem cells, and we're part of an NIH trial with this, with mesenchymal stem cells. And the other is cell therapies, which I think you're going to hear I'll talk about later, which is where from last year, where a certain type of antibody primed T cell therapy helps people with serious disease. And CAR T therapy is a very expensive, complicated treatment, but it has been used in hematologic malignancies. It's been used in multiple sclerosis and myasthenia gravis. It's been used in lupus, scleroderma, dermatomyositis, and Sjogren's, where we pherese the patients so to remove their white cells, select a certain type of white cells, perform a gene transfer, then expand it, infuse it in the patient. And in about 85% of published cases, it's been shown to be successful. So in summary, considerable advances have been made in understanding the pathogenesis of lupus. There's evidence that the innate immune, autoinflammatory, environmental factors play a major role. We know that nervous system involvement is exploding with our understanding of why people have lupus fog and can't think clearly. The glial cells play an active role in promoting cytokines releases and inflammation. We know that the autonomic system and vasculopathy, or alteration of flow, plays a role in many type 2 symptoms. And we know that in addition to just drugs, there's a whole host of other innovative approaches that will change. So I'm going to stop here, and everybody could stretch for 3 to 5 minutes and fill out your cards, and then bring up, and I'll answer your questions. Thank you. Has there been evidence that COVID and the COVID vaccine have become common environmental triggers? Well, lupus patients who get COVID tend to get COVID at about the same rate as everybody else, maybe a little more. The severity of the disease tends to be maybe a little worse. COVID vaccine reactions are a little more common. The confounding factor is a lot of patients are on, let's say, Cellcept or Cytoxan or methotrexate or other immune suppressants when they get the vaccine. We should probably hold those drugs before they're vaccinated. There's some people that react terribly two vaccines with lupus, but nevertheless, the American College of Rheumatology finds that the overwhelming majority do fine and recommends that everybody get all appropriate vaccine unless there's certain mitigating circumstances. Please address lupus and lung inflammation. Well, lupus can affect the lung in many different ways. It can affect the pleura, which is the lining of the lung. In other words, when God created your lung, it came gift wrapped, and its inflammation of the gift wrapping causes pleurisy or pain on taking a deep breath within the lung or within parenchymal tissues. We can have the interstitium involved, which is interstitial lung disease. We can have pulmonary hypertension. We can have alveolar hemorrhage or hemorrhage bleeding into the lungs. And there are about 10 different types of pulmonary disease in the lungs, some of which are inflammatory, some of which are vascular, and you always have to rule out infection. And you also have to rule out the fact that people with lupus who are immune suppressed often can get more reactions or more infections from this. Now, with the advent of high resolution CT imaging, pulmonary function tests, and specialized scanning, we can identify and treat pulmonary disease better. Long-term use of Plaquenil concerns. So the risk of eye damage from Plaquenil after 1 year of use is 0. The risk of Plaquenil damage after 5 years of use is 1%. The risk of Plaquenil toxicity after 10 years is 2%, and then it goes much higher. So that after, let's say, 20 years, it could be as high as 15%. Plaquenil promotes melanin deposition under the skin. That's one of the ways it helps protect you from the sun. And melanin pigment in the eye, especially in the macula, can cause visual damage. There are very rare other complications of long-term Plaquenil to the heart, but for 99% of people who are going to take Plaquenil for a few years and not going to do 10 years, it's not an issue. If you're on Plaquenil for more than 10 years, there is now a new test, a new imaging test that called a QCT, which can be done in a retina doctor's office and can determine if you have early damage from hydroxychloroquine or Plaquenil, in which case the dose may need to be modified or stopped to prevent anything from occurring. As far as the second part of the question, which is long-term damage from Benlysta, we published a paper recently of 13 years of it. We couldn't find any. Benlysta doesn't kill cells, it modulates cells. And we just have not seen any long-term damage from it. Okay. Has there been, okay, we did that. Okay, again, this is another, the other thing, another question about Plaquenil in the eyes. Are there clinical trials for eye damage? No, it's just looked at. We now have other ways of measuring it. Plaquenil can cause corneal issues, which is the front of the eye, which is where you get shadows or bright lights or flashing lights. And that's something that goes away when you stop the drug. It's not a permanent issue. If you have type 2 lupus, can you still have type 1 lupus? Yes, you can have type 1 and type 2 lupus. And that's being looked at right now by some of the work by Dr. Bezetsky and Dr. Lipsky. Okay. Is Plaquenil a targeted therapy? No. A targeted therapy is a therapy that, let's say, kills one cell or addresses one molecular interaction. Plaquenil raises the pH of the cell. it makes an acid cell more basic. And when it does that, it turns off signaling between cells so that a specific so that a specific cell cannot tell another cell to become inflamed. And that's what Plaquenil does. Okay, if certain drugs can cause lupus, does stopping the drug reverse the lupus? Drug-induced lupus is not really lupus because it goes away when you stop it. There's only 2 or 3 of the 75 drugs that actually are associated with ongoing lupus that doesn't go away. The most common of which is something called minocycline, which is used for acne and should be used very carefully. What else do we have here? Any recommendations regarding diet or lifestyle that support health and lupus activity? Okay, so there's diet, which is really eating a well-balanced, healthy diet. We don't have a perfect lupus diet yet. Exercise, we know that isometric exercises are better than isotonic exercises. Isometric exercises include Tai Chi, yoga, Pilates, and they're stretching and strengthening, and they prevent bone demineralization, osteoporosis, and muscle wasting and atrophy. Isotonic exercises such as weightlifting, bowling, tennis, golf, can promote inflammation and should only be used if your disease is under good control. The weather plays a role. Change in barometer is associated with worsening lupus symptoms. It doesn't matter if it's hot or cold or wet or dry, but if the weather goes from hot to cold or wet to dry, lupus patients become a little stiffer and achier. We know that stress makes lupus worse. It's very, very non-specific. We know that anxiety reduction measures anything that works with the sympathetic nervous system that reduces that type of annoyance in your lifestyle is helpful. For nephritis, does the blood work such as glomerular filtration rate indicate the kidney function, or does the patient need to biopsy? Okay, so usually blood work such as creatinine, BUN, albumin, and looking at the urine can give us a good idea with kidney function and how much protein there is in the urine. Biopsies are used if that doesn't give us the information, or if it's going to change our treatment. And we're working on lots of new biomarkers which would help us examine that. If you have a child, what is the probability that my child will have lupus? If you are a lupus patient, the chances are 10% that your daughter would have lupus and 2% that your son would have lupus. Can you speak to the cognitive challenges associated with hydroxychloroquine or Plaquenil? Well, it usually improves it. Takes about 6 to 12 weeks to start working, and it does improve cognitive function. It does not make it worse. If one has prednisone-induced retinopathy, what is the likelihood of getting hydroxychloroquine-induced retinopathy? Is there a relationship? And the answer is prednisone causes cataracts and increases the pressure and causes glaucoma. Prednisone does not cause a retinopathy. It's different than what hydroxychloroquine does to the retina. How long should one try Safnello before determining its effectiveness? So Safnello is also known as anifrolumab, and it's a biologic agent, the second biologic agent other than Benlysta that's on the market. It inhibits interferon. It's particularly good for skin disease. It's also good for joint disease. And usually we give patients a 3-month trial with it. It's an intravenous that takes about a half hour. There's a booth here where you can talk to the sponsors of the drug and find out a lot more detail. How effective is Benlysta in reducing inflammation in the lungs? The answer is Benlysta is very good with lupus pleurisy. As far as interstitial lung disease, it's probably not that good. We would probably go with mycophenolate or Cellcept or rituximab. Does the blood pressure medicine amlodipine and or post-cancer treatment tamoxifen contribute or cause lupus? Amlodipine is also known as nifedipine, and it's used to manage the Raynaud's or color changes in the hands. So it helps lupus. Tamoxifen is a medication given that's a hormonal source, and it's used in patients with breast cancer. And it should never be used with Plaquenil. There's a contraindication to the drugs interacting. And also tamoxifen can be associated with more joint pain. So we don't use tamoxifen all that much, but there's a group of people that need it for about 5 years, and many of them tolerate it. So it's worth trying if you're not on Plaquenil. And as far as radiation therapy, we get questions from radiation oncologists all the time. Is radiation therapy safe in people with lupus? And the answer is there is something called interstitial changes that you get in the lung or scarring in the lung from radiation therapy. And if you have scarring in the lung already, it's not a good idea to get radiation therapy. But if you don't have scarring in the lung, it's okay. What is the span in mortality rate increase in lupus patients who have fibromyalgia? Well, fibromyalgia is not a disease. It's a syndrome. It simply means I touch you, you hurt. And fibromyalgia is not affected by life expectancy other than just stress, anxiety, or depression. It does not influence that. Okay, let's see if we've covered. I think we've covered all but 2 or 3, which were personal. Let's see if there's anything else. Can you get lupus from the COVID vaccine? Why? It's very, very rare. It's possible. People have been getting lupus for years from a variety of vaccines, but the percentage is like less than 1%. Is Benlysta a good medication to treat lupus, and what's the major side effect? Benlysta is a general lupus medication that has an effect on B cells. And it is, according to the guidance document that was recently published by the European lupus experts, it should be the drug of choice for lupus patients after having had a low dose of steroids that doesn't work, or Plaquenil or antimalarials that don't work. And it helps all types of lupus. It is not approved for central nervous system. It is the only drug approved for children with lupus. It did fail its African American study, so it may not work as well in African Americans as it does in others, but that is controversial and has something to do with study design. Can lupus ever be reversed? Some studies show that it can. So about 20% of my lupus patients never need any medicine. Let's say those with skin disease or certain very mild disease, they can get by with ibuprofen. So there are some lupus patients that don't need medicine. There's some lupus patients that need medicine for a short period of time. And lupus does tend to burn itself out with menopause. So they say it's like a good wine, it gets better with age. It's lupus, if you have non-organ threatening disease, it can be altered. So let's see, what time is it here? 50. Okay, so we have about 5 minutes left. Anybody want to ask questions from the floor? Yes.
If you got your COVID shot in September 2023, would you have to, you have your lupus, you take it now, another one? How often do you take them?
It depends on the FDA recommendations, but if you're doing primary and with all that, there's no reason to deviate from the FDA recommendations, but the guidelines are changing all the time. Okay, any other questions? All right. Okay, thank you.
Thank you so much. Okay, that was great. Thank you, Dr. Wallace. Our next speaker is here on behalf of Parexel. Dr. Reif reached out last year and wanted to educate the community on clinical trials. And we did a series of Facebook Live with experts, which we hope you've seen. And one of the things we learned from the community was there was a lot of hesitancy to participate in clinical trials and a lot of fear. And so one of the things that we really want to do is educate the community on the benefits and understanding and addressing the fears. So Dr. Reif.
Let me quickly fix this. Good morning, everyone. How are you all doing? Great. It's not easy. It's not easy to peel yourself out of bed to make it at a 9 o'clock conference on a Saturday, isn't it? So thanks everyone for making this happen. And I want to quickly introduce myself. I'm Andreas Reif. I was a practicing rheumatologist across town from Dan at USC, UCLA, and I worked with Maggie, among others, for many, many years. And then after 27 years, I said to myself, it's time for me to do something else. You know, when you are still, at least I feel still young enough, that I thought to myself, it's time to think about learning a different job, doing something completely different. So I signed up for this company that Susan just introduced to you called Parexel. Parexel is what we call a contract research organization, or a CRO. So what these guys do, or what we do, is essentially we take the pipeline for lupus and other diseases that pharma industry brings up, and they come to us and say, we have this product. What do we do with it? We think we could use it in lupus. So they speak to me, and we talk about, okay, so if you want to test this medication in lupus, what does it take to bring a medication like this to market? How long does it take? How many patients do you need? What countries in the world do you have to go to? And a lot of different considerations that I'm going to talk about. So that's my job right now. And I'm advising basically the pharma industry of how to bring new lupus medications to you as the patients. So we have about an hour today, and what I want to do is I want to talk to you first about what a clinical trial is about, a little bit of history about clinical research, because there's a reason why some people still think, I don't want to be a guinea pig for pharma. Okay, you never know what they really do, and it's all dubious, and what are they really studying? So we talk a little bit about where this may come from. I want to talk to you a little bit about the life cycle of a lupus drug. Life cycle means, from the time a scientist in the lab actually discovers something that he or she thinks is actually an effective medication for lupus patients. So how long does it take from that point on to bring it to you as a patient so that your doctor can prescribe it? Then I want to talk to you a little bit about participation in a clinical trial and why you should do this and why this is so important that you are part of it. I know again, as we talked about, there are some perceived barriers, misconception about what happens during clinical trials, and makes you scratch your head and saying, I'm not sure if I want to do this. Then I want to talk a little bit about minorities in clinical trial. You just heard Dan talk about Benlysta, and you heard him talking about the fact that African-American patients do not respond so well to Benlysta. Question is for me, okay, why did it take 3 clinical trials to figure that one out, right? Did anybody ever say, wait a minute, wasn't it the African-American community that, had always difficulties with lupus drugs? And by the way, that was not the first one. Mycophenolate, same story, right? So we need to make sure that we have the right patients in the right clinical trials. So we'll talk about that a little bit. And then I'm going to guide you along to figure out if you are interested in, if I convinced you to participate in one of those, how do you actually find out what's going on? Where can I participate? Where can I be part of the team? And then we have a Q&A at the end. So if that's okay with you, we'll continue. Okay. So again, why am I doing this? Why am I here? Why are you here? Okay, you are a critical part between what's coming out of a lab, so what's ultimately becoming a lupus drug and is a prescribable lupus drug, what the FDA and the EMA is the European Regulatory Agency, so it's the European equivalent of the FDA, ultimately allows to be on the market, and then, and us. So you are the key person, really, you are. So I want to come back to Benlysta. We just talked about Benlysta. Has anybody ever wondered why it took 50 years, 50 years between the discovery of prednisone as a good lupus medication and the discovery or the final approval of Benlysta? 50 years. That's forever, right? And you wonder, how is that even possible, right? And the answer is these clinical trials are complex. They need a lot of time, but they need you. They really do. You need to be part of this developmental process. You need to be involved in this. I always told my patients, and I know that's why you're all here, be part of the story. Okay, and being part of the story is not just going to a Lupus LA conference. It needs to be you as part of the entire process where we bring new medications to life. Okay, so you need to be an active participant in this, because if we have your support, we're going to get this done faster than 50 years the next time. So what are why is it important to participate? Well, not only can you contribute to medical research, because that is before a drug gets approved, it's a research study, right? But you help improve quality of life. And in fact, when you look at the healthcare system nowadays, and I preach to the choir here, I get that. But you know how difficult it is to get access to a good doctor, access to get to see a qualified rheumatologist. How long does it take? How many of you have been around seeing many doctors before somebody said, I think it might be lupus, so you should probably see a rheumatologist. You know how that goes, right? Forever. And unfortunately, because of lack of access, I have to tell you, a clinical trial in lupus, once you are diagnosed, is actually a way that you can see your rheumatologist much more often. And not only that, we actually monitor you much more often. Why do we do this? Well, when we develop a clinical drug and a clinical trial, we are damn careful that nothing goes wrong, right? because who wants to have a bad side effect happen in a clinical trial that can kill an entire program? And pharma invests millions and millions of dollars into a study. I give you a ballpark. An average study in lupus with, let's say, 250, 300 patients costs on average about $60 million. That's a lot of money. And they don't want to screw that up because they want to make sure that this ultimately gets approved so they can sell it. And for that reason, we monitor you during a clinical study much more carefully. You're going to get labs more often, you get exams more often, x-rays, you name it, all that stuff. But ultimately, and that's the red dot here, ultimately what it comes down to is you are all participating to improve the quality of life for yourself and for patients worldwide, just like you. This is really what this is about. Because the treatments that we have today are less than optimal, and you know all that. So when you look at this as from a big picture kind of perspective, yeah, about 30,000 known diseases worldwide. Okay, out of these 30,000, actually only a third is treatable today. Treatable and even curable. A third. Think about it. That's almost nothing, I would say, right? So we need to work to close that gap, and we need to do this together. So what is a clinical trial? So here's a definition. It's basically a research study that tests either a medication or an intervention like a surgery, or even a device like a pump, or a testing, like a finger prick test device that you can do this at home. So, and these clinical trials are the primary way so that we as researchers and scientists, we can determine if this actually works for you, and that ultimately again becomes an approved drug that your doctor can prescribe and you can take safely. So I told you a little bit about the fact that it takes a long time for medication to get approved, and that's what we call lifecycle management, okay? What lifecycle means is, in order to get one lupus drug approved, on the top of the filter here, you need about 10,000 different compounds to come up with one single drug. So now if you scratch your head and say, why does a clinical trial cost $60 million? That's the answer, right? Because the first thing that you do is a lot of searching and refining and improving, and then you bring it maybe into a preclinical model like a mouse or a rat or some sort of an animal trial. And even if you pass all those stages and the lupus mouse tells you, oh my God, this medication works amazing. It cures the entire mouse and the mouse is happy. And then it goes into clinical trials with humans. And we realize once more that we are not mice. Okay, we are just not like mice. In fact, the FDA has told us, if you ever want to come up with a lupus trial, you better do not show us any more mice data. We don't want to see them. Okay, they are not helping. Okay, so ultimately, out of those 10,000 medications that go into the pipeline, one will make it. And along these long journeys of trials and errors, you spend a lot of money. So if you ever wondered again why pharma charges so much money for these medications out there, this is one of the reasons, because they invest a lot of money before they come to you. So this is what we call life cycle. Okay, so life cycle starts with the discovery in the lab, then again it goes to the animal trials, then it goes into these various different human trials, and I'll talk about this in a second. And then the FDA or the EMA, the regulators, they look at the data. There's a big meeting and you develop tables and tables of data, and they check every single safety event that happened during the trial, and they want to make sure that there are no bad side effects, and then ultimately it becomes an approved drug. But then even then, the life cycle of a medication is not over, because even after it is approved and your doctor can prescribe it, pharma still invests into these clinical trials that do post-approval studies. Because the fact is that a lot of people that participate in clinical trials they are not real life. They are sort of the professional patients, a lot of them. They participate because they get something out of it, like money in the early clinical trials, for example. And then it turns out, like what I just quoted with Belista, a lot of African-American patients start using it. And then all of a sudden somebody finds out, well, that's not really what we saw in the clinical trial. So reality on the ground is totally different, right? This is what we call a post-approval trial. So let's take a look back for a moment, okay? Because I know many of you are in this room that say, well, I heard a lot of bad things happen during clinical trials. And this is something that a lot of people don't want to really talk about. But the fact is there's a history to clinical studies. And that history was not always very nice and not very optimal. So there were a lot of big mistakes made in the past that made people suspicious. And even though that may have been a really long time ago, that kind of sticks in the memory of people, right? So I want to give you a couple of examples. The thalidomide trial. For those of you who grew up in that area, thalidomide was a medication that was used to help pregnant women sleep. It was a sleep medication, okay? And then it turned out all of a sudden that the babies that were born to these women who took these medications were missing limbs and arms. And that was not recognized early enough, and the trial wasn't even stopped. The Tuskegee experiment, very famous story in the 1930s where African Americans were treated for syphilis. And even though the doctors knew who got what, and it was clear that this was not a fairly balanced clinical trial, this trial went on and on and on, and it caused a lot of uproar and political changes. So with that in mind, and not to mention what happened in the concentration camps, with these experiments in prisoners and all that. So it's a sad, sad and dark chapter of clinical research. The good news is after all this happened, people got together worldwide and said, we cannot do this ever again. We need to make sure that the clinical trials become safe and that the patients who are in these clinical trials actually understand what they are doing and what they get into and that it's transparent. So there are a couple of these meeting reports, if you will, called the Nuremberg Court, the Declaration of Helsinki, and the Belmont Report that actually said, if we do clinical research today, we need to make it safe for the patient and the patient needs to know what's going on. So we now call this thing ICH GCP. So that stands for Good Clinical Practice in Research. And I'll break this down for you in a second what that means, okay? So when we do a clinical trial nowadays, it's not just we say, oh, okay, we have this medication and we're just going to throw it out and do it. That's not how it works. Before you start a clinical trial, you need to actually apply to the regulators, the FDA or the EMA in Europe, and say, this is the clinical trial we want to do. What do you think? Is that okay? Well, they will tell you, okay, so well, if you want to do that clinical trial, you have to answer a couple of questions. First of all, social value, okay? Just because you want to sell a medication doesn't mean that, it makes actually a significant difference. So you have to have a value behind this. Does this medication really help to improve quality of life? Does it advance scientific knowledge? It's not just, this is something, we are interested in, but it may not really do anything for any patients. That's not good enough. It needs to be scientifically valid. Scientific valid means you have to have the right research methods, the right patient numbers in the trial, and you need to do something called statistics. Statistics means you compare A to B, and A, if that's your drug, needs to be a lot better than B, or, at least there needs to be a major difference. Otherwise, forget it. Fair patient selection. I just talked about that. So it's not just about a trial for patients who do this all the time. No, it needs to be a trial for everyone. Again, and when I say everyone, I particularly remind you again about the minorities. How many more times do we need to learn that, again, medications in lupus do not work as well for African Americans or for Hispanic patients or for Asian patients before it finally sinks in, right? So we need to make sure that we design these trials with a lot of these patients included, because they also have more severe disease than Caucasian patients, for example. So it needs to be fair patient selection. And then there needs to be a favorable risk benefit. You know, Dan has talked about, about mortality with lupus. So we all know this is a disease that can kill. Okay, so this is a serious condition, and we need to take a serious intervention to stop. So serious diseases require serious medications. Serious medications have side effects. However, it's not like patient is, the disease is cured, but the patient died as part of the treatment. That's not going to work, right? So it needs to be what we call a favorable risk benefit. A couple more. Informed consent. So as you participate in a clinical trial, you're going to get a document. And in that document, it should explain to you in the language you understand. And I repeat it, the language you understand, what this is about. Not 20 pages of and the B cells and the T cells and, nah. Okay, and please, if this is not written in the language you understand, please ask the people that are involved, your doctor, the research nurse, or the research coordinator. You should never participate in a clinical study if you do not understand what this is about. And what I did for my patients in the past, I sat down with them and I said, okay, this is the official form that I have to give you and that you have to sign before we enroll you into the clinical trial. But let me do something with this first. Put it on the side, take it home, read it at home. What I'm going to do for the next 20 minutes, 15 minutes is I'm going to lead you through it. And I give you the key points for this. And you can ask any questions you like, because I want you to get it before you make that signature under that form. And then there's such a thing as an independent review. So just because you agree, the doctors agree, the FDA says, well, okay, let me look first what you have put together here, okay? And so there's a committee of scientists to make sure that all the dots are checked and all the crosses are in the right place, okay? So that you don't have to smuggle something in the back or so. No, it needs to be clean, right? And then ultimately, but not least, is respect for human subjects. Okay, we never do clinical trials anymore where we are, where we are not providing you the maximum safety. Now, granted, as we embark on a clinical trial, there's a lot of stuff we do not know. That's what a research study is, right? We need to learn. And so we can inform you about what we think is going to happen, but there might be stuff that happens that we were not even aware of. So that's what a clinical trial is really all about. But we provide this with a maximum protection for you. Okay, there are a couple of types of clinical trials I want to quickly talk to you about, because they're not all the same. So we talked about when a medication comes out of the lab, right? It's just a chemical formula, and then you either swallow it as a pill, or you infuse it through your vein, or you inject it into your skin. But the first step in a development life cycle of a drug is what we call a phase 1 study. Phase 1 study is typically conducted in healthy volunteers. So when you drive up the street here in Glendale, at the Glendale Adventist Hospital Park-Cell, my company has a unit called an early phase unit. They have 60 hospital beds in that unit, and there are people checking in every single day, participating in clinical trials for all kinds of diseases. So some of them live there for about 2 or 3 weeks while they're doing clinical trials. They stay in the hospital. They can order food in. They have TV and video games, they just check in. And a lot of them do this because they get paid a lot of money to do this, right? So that's how we study how these new medications behave in healthy volunteers. So we do not start with you as lupus patients, we start with healthies. Now, no brainer for you, I get it. You will say, well, okay, well, the healthies are great and they are doing well, and they are young adults, and they have healthy livers and healthy kidneys and healthy brains. That's not me, right? Oh, my kidney is not doing so good and my lupus is active. So obviously the next question is, all right, now we know it's safe and it works in healthies. But how about a lupus patient? So that's where phase 2 studies come in. So in a phase 2 study, we take a medication into human patients, in lupus patients, for example, like you. We are including somewhere between 50 to 500 patients in the phase 2 clinical trial. And what we typically do is we say, okay, this medication comes in dose A, B, and C. So do we need a lot of it? Do we need a little of it? And then ultimately, once the phase 2 is done, we typically have arrived at the conclusion that this dose is the best one. It's as good as the highest dose, but it's better than the lowest dose. So we pick one dose, and that's what we're going to take forward into the phase 3 trial. The phase 3 trial is the biggest one of all of these. And the phase 3 trial is what the FDA or the EMA wants to see before they say, okay, this medication works and we give you the approval to sell it. And then we talked about post-approval, right? And that's the phase 4 study. So by that time, the medication is typically approved, but we do a real world study typically. So we give it to the rheumatologists in the world and say, make sure what we have seen in the clinical trials actually happens in real life. And you see the price tag on the bottom here, right? I talked about it. So phase 2, again, is 20 million on the low end, 60 million on the high end. But the phase 3 trial can set you back up to 120 million bucks. That's a lot of money. And again, when Pfizer tried to hire me once, they said, we have a job for you. You can become a lupus drug developer. And I tell you what your job is going to be. And I said, oh yeah, that's great. I can tell you exactly what works. And now they said, no, your job is going to be to take our pipeline forward and kill every medication to your best degree. And only that one that you cannot kill because it's so good, that's the one we want to approve, because we are not going to spend 120 million bucks on a drug that's never going to see the light of day and we cannot sell, right? Makes sense. So let's say you participate in a clinical trial. What's going to happen? Well, okay, so you signed this informed consent sheet. You know what you're going to get into, and your doctor says, okay, see you Monday morning. All right. So Monday morning happens, and the first thing you need to do is you call your sister up and say, hey, can you take care of the kids because Monday is my study visit? All right. Sister says, yeah, well, that's not a good day. So you scramble around and you look for your mom to take care of the kids so that you are free on Monday morning. Okay. Then you hop into the car and then you find out, strangely enough, the 10 is completely blocked again and it takes you 2 hours to drive to get to the study site, right? Okay, 2 hours have been toasted away. And now you arrive at the hospital where the clinical trial takes place. So the study nurse greets you and says, okay, before we get started, and you see the doctor go to the lab. Second floor, here's the sheet, give it to them. You go down to the lab, and of course you're sitting in the waiting room and you realize that there are 100 of others that do the same thing that day. So you sit in the waiting room to wait for your labs. It's finally done, 1 hour has passed. Then they say, okay, so once you're done in the lab, you're gonna see the doctor. Okay, so you go up to the doctor. Well, guess what? The doctor is late today. He has another inpatient that he had to take care of. Okay, so you're sitting and you're waiting. And then he finally shows up, and then you have to go through a pretty extensive exam. So what you will realize, oops, something must be different because I'm now in a clinical trial. Now the doctor looks at every single joint. He looks at my rash and he measures the extension of the rash. Well, why did he never do that before, right? So that's a clinical trial, okay? So now we're having tools that assess how big is the rash, how red is the rash, how large is the rash, all these kinds of things. All of a sudden, attention is being paid to all these details that you were wondering, wonder why that never happened before, right? Then they say, oh, by the way, we forgot you need to get a chest x-ray. Because remember, we are looking at lung disease in lupus. We discussed that just now with Dan. Okay, so we need a chest x-ray or a CT scan. They tell you 5th floor, radiology department. Okay, you go up to the 5th floor. It's now 6 hours into the study visit. And guess what? You end up waiting in the waiting room for the radiology department because, of course, you're not the only one today that checks in for a chest CT. And then once this is finally done, you're probably able to go home. So bottom line, yes, you're investing a lot of time. And yes, we recognize that this is a commitment that we are asking from you as a provider and as a participator in a clinical trial, that, you know, we recognize you have a life, you have family, you have kids, and it takes a lot for you to participate in something like this. But keep in mind why you're doing this, okay? And in order to make it easy for you, we're going to actually pay you to drive for the gas that you use. We're going to pay for your parking. We actually give you a gift card that you can sit in the cafeteria between the x-ray and the doctor's visit, so you can eat in the cafeteria, at least something like that. That's what we can do. But there's this other component of this, and this is called DCT. DCT stands for decentralized clinical trial. And I just want to talk to you a little bit about this. Because we realize this, it takes a lot of commitment for you, and hours of waiting and you know, visits and driving. There is a new way we can do these clinical trials, and we do it in a DCT way. DCT means we bring the trial to your living room. In other words, no, you do not have to drive to the doctor to see the doctor. No, you don't have to go to parking and all that. We're going to do a study visit at home. Okay, so you can take your laptop or your computer and your doctor is on the screen. Some of the tests that we do, you can fill out yourself in a little diary or a little, you know, like your cell phone. There's a questionnaire in there, you can fill that out. So not every single visit we do for a clinical trial has to be done in the hospital where you have to go to. So we can do some of these in your living room at home. And by the way, just maybe a couple of data on this slide. So, and shows you kind of why we think about this decentralized trial. So there are about 40,000 clinical studies going on in the US as we speak, not just for lupus, right? All kinds of different diseases. And 80% of those clinical trials are delayed. Delayed meaning they're, you know, they are not enrolling enough patients. They don't meet their timelines. Why? Because patients say, look, you know, I really like this medication. It's cool. I want to help, but I have a life, and, you know, I don't have the time to drive and to wait 8 hours every single time I'm there. So, and because of that, even though as motivated as some patients can be, a lot of patients ultimately drop out. Okay, they drop out of the clinical trial. They said, well, you know, it started well, and, you know, the medication was good or maybe not good. And so after 6 months, they say, well, thanks so much, but sorry, I'm out. And that, of course, is a big problem. So when you look across all of these studies, on average, a third of all patients drop out of clinical trials for various reasons, you know, not just side effects. So that's why we try to make this easy for you and try to bring this trial home to your living room. Some people ask, okay, what is actually, why are people motivated to participate in these clinical trials in the first place? Well, when I first thought about this question myself, I thought, well, they have lupus and they want to make themselves better, right? I've tried medication A, I've tried Benlysta, I've tried Ritux, it didn't work. So now the doctor tells me this is a great medication, so I'm going to do this and see if that works for me and it makes my life better. Interestingly enough, I'm very proud of you all. This is really not the reason why a lot of patients sign up for a clinical trial. The number one reason is actually to help scientific knowledge and to improve the lives of others. Isn't that interesting? You know, you would think that everybody says, well, I'm not doing well, so that's why I'm doing this. No, it's actually for really advancing science. So this is, in my mind, this is really great. And then the other thing is, you know, improve my condition, only 15%, to make some money, only 5%, and then to receive free medical care, 3%. Now, I'm not so sure if I believe those 3%, honestly, because again, our access to care has dramatically worsened in the United States. And by the way, this is not just US. We have similar problems in Europe and Latin America, where people just cannot get to see a specialist anymore, right? So a clinical trial definitely allows you to get access. So let me come back to my my favorite topic here that I mentioned now multiple times, but that's the involvement of minorities in clinical trial. Just a couple of data that shows you what I'm talking about. If you look at just the African American population in the United States, they represent 13% of the US population. However, when you look in clinical trials, it's only 7%. Hispanics, 18% of the population and growing, right? Only 11% of that population participates in clinical trials. And then last but not least, in the Asian population, it's probably even more drastic. 6% of the US population total, but only 1.7% of the clinical trial population. So that needs to change, right? Because again, it's not just about minorities participating, but we need to learn to avoid mistakes that we have made by approving medications and then after the approval realizing, oh, we should have had more African American patients in it because we would have noticed that it's not working so well. So why is it that minorities are underrepresented in clinical trials? Well, we talk about it. So there's a certain mistrust in certain communities, and it's based on historical fact. It's not that they are making it up. Stuff happened that was not good, and people don't forget. So that's where a lot of this mistrust comes from. Uncertainty. I call it the guinea pig syndrome, right? So what is it really that they do? And then a lot of this uncertainty comes from the fact that a lot of people do not understand what's actually going on or what this medication really does. So that's why I bring back to what I said. Never sign up for a clinical trial if you are not sure you understand what you're getting yourself into and you really know what's going on. Now, access we talked about. A lot of these lupus trials are not done in your primary doctor's office. It's done in your rheumatologist's office, right? And again, it's not easy to get to see a rheumatologist these days. And then last but not least, coming back to the eight-hour visit that we just talked about, you have a life, you have a job. You tell your employer, hey, good news, I just signed up for a clinical trial. And by the way, I'm going to be out every Monday and every Wednesday. So I'm sorry, I'm not going to be here. And you show me the employer that says, of course, anytime, right? So they give you a hard time. Okay, let me guide you a little bit through how to find out about clinical trials. So when you ask the patient population, how do you know about clinical trials? Where do you get your knowledge from? How do you know what's going on? Most of the people get it from Dr. Google. Okay, they ask Dr. Google in a private consultation on their computer, dear Dr. Google, which clinical trial is going on? And Dr. Google will tell you on that. Others learn it through media, TV, radio, newspapers, to email, advertisement. Then they can see when you visit your doctor's office, there's often a flyer at the checkout table, right? We are recruiting for clinical trials, take this flyer, you can take that one. Or in fact, which should always happen in my mind, your doctor is actually talking to you about this. Now, as you know, your doctor is always busy, right? So why don't you ask your doctor and say, hey, doc, by the way, are you doing any clinical research studies that I might be interested in? Oh, yeah, it's great that you mentioned that. Now that you say that, in fact, there is something. So Dan Wallace, for example, he's a great colleague of mine. So he's involved in all kinds of clinical trials. Trust me, he has a whole list of clinical trials that he's involved in every single day, okay? So he's a great resource. And then sometimes you get a mail or a flyer or something in the mail, or family or friends tell you about it. But what I want to do quickly for you is try to convince you that Dr. Google might not be the personal best consultant for you, okay? There is this website you should probably know about. And you see it up there on the left corner of the slide. It's that website called clinicaltrials.gov, okay? So I would say if you type that in, bookmark it, so you always have it available, and it's actually fairly easy to navigate, and I'm leading you through it, okay? clinicaltrials.gov is every single trial that is approved by the FDA that's currently going on in lupus and other diseases that you could theoretically access. So if you would do this right now, you would find that there are currently, we are already in March, but as of January of this year, there were 85 worldwide lupus trials going on. So 85 trials you can choose from. And I'm talking about not just participating in a registry like, hey, I'm so-and-so many years old and, you can put me in a registry and then in 5 years, you ask me how I'm doing, not that stuff. I'm talking about clinical trials, so with the medication, right? So if you go into that website, clinicaltrials.gov, that's the thing you're going to see first. So then you go into that little box here that says condition or disease. Okay, and you do not need to type in this whole long word, lupus erythematosus, and what is it again? Otis. No, just type in lupus, and it's automatically going to pop up. Okay, and that's all you need to do. I mean, if you want, you can type US in there or USA, but you don't even have to do this because it's going to filter that for you automatically. So then you click on that search button on the bottom of that. And you're going to end up in a site that looks just like that. And now you see 176 studies. Whoa, 176, that's a lot of stuff, right? You don't need to go through 176 studies. You need to filter it, okay? So you click on the left, it says recruiting. Recruiting means these are studies that are looking for patients right now, not those that have already been closed or that haven't even started yet and all that. That's how you end up with these 84. And then you get this list of lupus trials that you see here, and you can click on anyone that makes sense to you or that interests you. So for example, here's the Safnelo trial, post-marketing, and this is in Japan. So unless you live in Japan, you may want to click on the Japan trial, right? Or you can sort it for US if you want earlier. And you can click on each of these clinical trials and it tells you where's the clinical trial being done? If I'm interested, what phone number do I call? These kind of things. So that's how you can find these clinical studies unless your doctor tells you already about those. This is maybe a lot better than asking Dr. Google. Another good way of finding out about clinical trials is you actually log into the Lupus LA website. Because since Parexel has been working with Lupus LA, we are actually posting the lupus trials that we are doing on the Lupus LA website. So if you visit the Lupus LA website, you can find a lot of these clinical trials. Now, granted, right now there's only one on it, I believe, but we decided not to post them unless they are ready to go. So some of them are delayed, but you will see a lot more coming in summer and fall of this year. So you can choose from those. There's a little window there, and you can click on that, and then it tells you all about the clinical trial and who to contact. Okay, almost done. So if there's a clinical trial you're interested in and you're asking yourself, should I really do this now or not, but you have sort of doubts, what is a good way to make this final decision? Well, you may want to talk to a couple of people about this. Talk to your rheumatologist. Talk to your friends, talk to your trusted advisor, like your local church or anybody that your social worker, and be honest and open and ask questions. If you're not sure, if you really want to do this, make sure that you are really going into these trials with confidence, not with a vague understanding of clinical trials in lupus are complicated. We are not expecting you to understand every little detail about this, but the concept of what you really have to do and what it takes from you and what we really want to look for, you need to understand before you sign. And with that, I want to thank you. I have a couple of Q&A questions that frequently come up after these talks. And you wonder, why is it that you don't talk about this from the beginning? But they are really different. And so I thought what I do is I talk a little bit about some of these questions that I've heard after our Facebook Live event that we posted to the Lupus LA website. And I bring some of these up right away. So maybe one of your questions that you may have right now is among them. So let's go through a couple of them. Who can I speak if I have questions before, during, and after a trial? I hope I could answer this for you, but the question is, the answer is, the best person to really talk to is the people you trust and your rheumatologist who's doing the study, okay? And don't let them run out of the room. Oh, I have another patient waiting. Nope. If you want me to participate in a clinical trial, you have to answer me these questions first. Now, some of the doctors that do these clinical trials, they have study coordinators or study managers. They know a lot about these trials. Frankly, sometimes they know even more about the study than the doctor does. So if that's a good person to talk to, by all means. Who will be in charge of my care during a clinical trial? Is it going to be a trial doctor or your rheumatologist? Now, that's an important point. Sometimes clinical trials are done in larger institutions. So let's say UCLA, USC, they do these clinical trials. Your community rheumatologist in Covina or wherever you are may not be really the rheumatologist who does this clinical trial. So in other words, if you're followed in the community and you ask your rheumatologist about a clinical study, and when they say, yeah, there is actually one happening at UCLA right now, you will have to be transferred for this clinical trial to see a rheumatologist at UCLA. That's the person who does the clinical trial. That doesn't mean that for your routine follow-up and for all the other stuff that you do, you can never ever see a rheumatologist again. Of course you can. But for study-related activities, that would be the trial doctor at UCLA, let's say, or USC would be the one that follows you mainly to this. Will I need to stop my medication for a clinical study? Important point. Unlike a lot of the other diseases, lupus is a tough one. Okay, so I give you an example because this discussion has come up quite a bit. A lot of people talk to you, or you have probably read about CAR T cell trials in lupus, right? CAR T cells, that's sort of the new latest and greatest, okay, in lupus therapy. But when you look at these clinical trials, it's not that easy because especially in a CAR T cell trial, what the trials require is for you to stop pretty much every medication you're on. Now think about this for a moment, okay? You have pretty bad lupus and you're just hanging on and you finally ended up on a combo that worked for you for a while. And now this guy, that study doctor tells you, well, we have to stop all of it before we even start the study med. That's a tough one, right? So most of the lupus trials that are out there, and I'm not talking about CAR T now, they allow you to continue on a certain amount of medication, okay? So for example, let's say you're on Plaquenil, let's say you are on 60 milligrams of prednisone. They will tell you, okay, you can be on prednisone, but not on 60, you have to go down to 40. You can continue your Plaquenil and you can continue your blood pressure meds or your vitamin D or whatever you take, right? So, which I want to divert it 1 second, is a problem actually, believe it or not. You know, there is a slide that I always show, and I did not choose to show you to you, but drug development in lupus is the graveyard of the industry, okay? And it's very similar to what I showed you. Out of 10,000, one makes it through, okay? The reason for that failure in lupus particularly is because there is no placebo arm, really. Placebo, just as a reminder, means you get a sugar pill. And we compare the medication against a sugar pill. But in lupus, it's not that easy because you cannot have a lupus patient be on just a sugar pill. You all know that. If you stop all these medications that you're on, you would immediately flare, right? So that's not going to work. So a lot of lupus patients in clinical trials, they are on background medication, prednisone, antimalarials, and even immunosuppressants like an azathioprine, Imiran, or mycophenolate, or all these. So that's why, do I need to stop my typical medication? The answer in lupus trials is typically no, but you may have to reduce some of them, okay? Next one is, how do the doctors know if my treatment is working? That's a good one. This talks a little bit about how we do clinical trials, and we call them double-blind placebo control. That's a mouthful, right? What does that mean? What that means is if we design clinical trials in lupus, we do not tell the doctors that give you the medication what they're going to give you. They don't know, and you don't know. You're going to get something that looks just like the study medication, IV or sub-Q or as a pill, but it may just be a sugar pill. But your doctor won't know, and you won't know. This is because a lot of people, trust me, when they enroll into clinical trials, and we tell them, this pill is going to cure your disease. And they take it, they get immediately better. Turns out later it was actually a sugar pill. That's what we call the placebo effect. Okay, people believe this is really potent, and they take it, and it get better just because they believe it gets better. So that's called the placebo effect, and that can be as strong as 30% of the response. So the way we know that this medication actually works is exactly through these extensive tests that we do. Every single time we see you, we do joint exams, we do blood tests, we do x-rays. You fill out questionnaires about your quality of life, how you feel. And that is important. That's why we, again, need you in these clinical trials. Here's my favorite story. We do an arthritis trial, okay? Patient comes in, has 46 swollen joints at the visit 1. Then you take the study medication. Study visit 5 comes along, and you are down from 46 swollen joints to 30 swollen joints. Your doctor will say, oh my God, you went from 46 to 30, you must feel amazing. And you stare at the doctor and like, what are you talking about? Okay, I feel exactly the same crappy as I always felt. So that's why we need your opinion. Just because we feel that this is so much better doesn't mean that it makes any big quality, I mean, it has a big impact on you. So this is where your voice as a patient comes in. What are the typical timelines from close of a study to the publication of the results? Depends on the study, but a phase 2 or 3 study, it can take up to 3 to 4 years until this is published. What happens if I experience a side effect during a clinical trial? Important question. Depends on the side effect. If it's, of course, a serious side effect, we may stop the medication for you. And on that note, just keep in mind, you have the choice to stop the medication at any time in any clinical trial. If you change your mind and say, it was a good idea 3 months ago, I changed my mind, don't want to do it anymore, you can get out at any time, okay? But depends on the seriousness of the adverse event, we may have to stop the medication. What costs do I have to pay if I take part in a clinical trial? That's a question that often comes up from patients. So the answer in general is none, 0. In fact, again, as I mentioned, we pay you to either we send you an Uber if you want, okay, and bring you to UCLA. We pay you for the time that you spend. We pay you for, you know, for the meals that you have, for the gas that you put in your car, these kind of things. Now, it talks a little bit about making money of clinical trials also, because this is the ethics. We do not want you to be in a clinical trial because you can make a lot of money of that. That's not ethical, right? And the regulators are very clear about this. You're not paying somebody to be part of a clinical trial. Now, in phase 1, the healthy volunteer trials, it's different. If you're a healthy volunteer and you want to help out, we pay you for that. But as a patient, we tend to not pay you to participate. This is not ethical. Now, we can still give you gift cards. We reimburse you again for all the ancillaries that you have, but the primary motivation for you to be in a study should not be that you're going to be rich afterwards. And last but not least, will I have checkups once the trial concludes? Yeah, and the answer is absolutely. You know, just because a trial is over doesn't mean we forget you. In fact, there are studies that are following these patients years after they have been in the clinical trial, even though the medication is no longer given. So we want to make sure that long-term safety is guaranteed. And I think that's all I had for you. Thanks very much. And I'm open for any additional questions.
Hi, thank you for your presentation. What happens to if one wants to continue after the conclusion of the trial? How does one access?
So is your mic on? I cannot hear you. The green light should be on. Can you repeat? It is on.
How does the patient continue to access the medication after the trial?
Yep. Very good point. Question is for those of you who haven't heard it, how can a patient can actually get access to the medication that they were just in the trial for until it's actually prescribable, or your insurance improves it? Bummer, right? Hey, I was in the clinical trial and it became very successful, and now it's out there. And oh, by the way, it costs $65,000 a year, and my insurance company said, we're not going to cover it. Right? Good point. So I give you one thing as sort of a side note on this. An indirect answer is Brazil and Portugal as the only two countries in the world that have come up with a law. It's the law there that if you participate in a clinical trial, you can have access. The maker of this medication needs to make it accessible to you until it's actually, unless your insurance approves it and you can get it otherwise. But if that's not the case, you get it for as long as you need it. Unfortunately, Portugal and Brazil are the only two countries in the world that do that. So it is true. There is, first of all, there is a period between you finishing the clinical trial and the FDA approving it and stamping it, and then it comes into circulation, and then the pharmacies need to get it. So there's often a little bit of a delay. So during that time, you may or may not get it. However, as I said, most clinical trials that are out there now have what we call an OLE, or open label extension. So it's a voluntary extension part of your study, during which the visits are no longer that frequent. You come in maybe every 6 months or so, but you can still get an access to medication during that time until it's approved and prescribable. Does that answer your question? So the open label extension trials can go up to 5 years, sometimes 10 years. That's usually the time period when most of these medications are already out there and approved.
Excellent. Excellent presentation.
Thank you.
Question. You said that you guys spend 50 to 100 million in development, and possibly at the end of the day, possibly $1 billion. Question for me becomes then, and also you showed the lack of Black participation, 14% of the U.S. population, 7% of the people involved in clinical trial. The question for me is, how much commitment do you have in terms of reaching the most vulnerable that actually need to participate in the trial? And then, I mean, if you spend all these years development, it may take, what, 10, 15 years to develop a medication.
Correct.
Then when you actually develop it and you actually want to get people involved in the trial, more often than not, you charge the victim with the crime and saying that we didn't show up. When it's hard to go to a party if you don't know the address, if you don't know who's giving the party, and you haven't been invited. And then they say, well, where were you? Why didn't you come? And then when you do develop, then you say, you come to the community and you say, okay, we got this trial. And then you give me 6 months and you say, we need 50 people. Well, I need 6 months to even actually create the trust factor between the community and you. And also we talked about, and when you did that slide about communications, well, and when at the bottom, I think you had 7 or 17% in terms of friends and family. Well, that's not always together accurate if you talk about the Black community, because I'm going to trust my barbershop and beauty salon before I'm the LA Times. I'm going to read the LA Times to find out what's going on. Then the Black newspaper Sentinel, I'm going to find out the truth of what I read in the LA Times. And I think what happens is there's not a really good relationship between clinical trials, research, pharma. And I understand that Tuskegee and all that. And I too, have a level of paranoia, but I took my blood pressure medicine this morning. I'm not so paranoid that I'm not going to take medicine. And I think, and as great as this is, and it's been a great day today. I live in Inglewood, right? For some people to come here is like going to the moon. You know what I'm saying? And especially if you're talking about during the week, that scenario you gave about the clinical trial, it's going to take about a day, a week, because to just get the 4 or 5 rush hour, it's going to take you a day to get here.
Yep.
You know what I'm saying? So I think what we probably, some of the things that we need to do is actually sit down and have honest conversation with each other, talk to each other as adults, not as children, in terms of being afraid whose feelings gonna get hurt. And just be honest in terms of how do we make these things work? Because again, if we talk about all these disease states and you talk about, I forgot how many you said diseases, 80,000 or something. Too often, sad to say, but the resources don't follow the greatest need. You know what I mean? And as great as this is, I don't, as many people, and even my family members that have lupus, they ain't coming to UCLA.
Can I hire you as my press secretary? You're hitting, you're hitting all the exact right points. So number one, this is why I'm here. This is exactly why I'm here. So let me tell you about something else I'm doing right now. And I confused my company about this tremendously. I said, guys, why I'm hired up with you? Well, because we pay you a lot of money. I said, no, you don't. But that's not the point. I'm here to de-academize clinical trials in lupus. So you know what that means, right? So exactly as you said, none of you guys are hanging out at UCLA, and that's why I said, first of all, I can tell you when a pharma company approaches us to do a clinical trials, they said, okay, so we thought about this, how are we going to do it? So we're going to go to UCLA, and then we go to Mass General in Boston. And then I said, wait, okay. This is not where you find the most vulnerable patients. They are in the community, and they are with community rheumatologists. And by the way, they may not even have transportation to drive 5 hours to UCLA and being stuck on the 405. Have you thought about this? Interesting thought. Okay. So this is what we are trying to do at Parexel. That probably also distinguishes us somewhat from the other. We always work with the same people kind of thing. And coming back to Benlysta, I mean, again, remember it took Benlysta a full approval before they realized we didn't have enough African American in our trial. And by the way, they didn't respond so well. So we had to do yet another $30 million trial to prove it in this particular population, right? So because they didn't think about this. But I also agree that we are not thinking about the barbershops enough. Okay.
At some point, we have to face the fact that we have to address there's well-intended ignorance and there's conscious stupidity. And that's a rough thing, but we have to grab a hold of that. And I think more often than not in research, they're well-intended, but they're ignorant.
Yeah.
And then some are just consciously stupid. And that's reality too. And I love what you said. I love the information in your decks and all that. But I think I would love to see the same particular presentation that you just gave in my city, in South Central, in LA, and in places where the people could pick, everybody don't need Uber, they can walk. We can do it in some church and stuff. It can be done. The question is, do we have the will to do it?
You call me, I show up. How's that? I'm happy to be there at any time. I give you my phone number and email, okay? There was a question at the back. Was covered. Yes, one over there.
You have the same participants in various phases of clinical trials, or you can only be in one phase?
Yeah, it's a good point. So typically we are not allowing, so first of all, when it comes to an interventional trial, in other words, if you take a medication, okay, you cannot be in other trials. You can only be in one. However, there are a lot of our patients that participate in a treatment trial for lupus, but at the same time, they're in a registry study. So that's the registry you sign up. You are a lupus patient and we follow you every 5 to 10 years just to see what happens to you. We are not giving you any medication or anything like that. We just want to see what happens to you over time. So these trials you can be in, that's not a problem, but interventional in terms of taking different medications, you cannot. I think, yeah.
Thank you very much. I appreciate your talk. If you're on Medicare, usually you can't take advantage of drug company promotions, et cetera. So if you're in a trial, part of your slide, I missed the part where you discussed how they work in conjunction with your insurance. If they don't pay 100% or they just do pay 100%.
Yeah, so first of all, if you have been on some of these biologic medications, okay, that they are usually the most pricey ones, okay, where your copay can be in the thousands even. The drug companies typically nowadays offer compassionate use programs. So what that means is, let's say you have been in a clinical trial for one of these biologic newer medications and you cannot get it prescribed, or your insurance company only covers a certain proportion of it. You can actually go to the company's website and apply for these specific programs. So they tend to give you vouchers, or they can even, in some cases, waive the copay altogether so that your doctor can prescribe it without you paying out of pocket for it. Most of the companies now offer these kind of programs. Now, they might be time limited for a year or two, but at least it gets you sort of into the game for a while. Generally, and Dan commented on this earlier, my general rule of thumb for any of my patients was always, if you do not respond to a medication within 3 to 6 months, and you really have no response and it doesn't really do anything for you, you do not want to hang on and try it for 2 years and pay for it, because it tends to not get any better after that time. So at least it's time limited.
Thank you.
Hmm.
And one more question.
Yep.
Not to be antagonistic, but sorry, I will. UCLA asked me to be in a study, and my doctor knew all of my personal, insurance and issues, whatever. And then I was going to do the study, but reading the fine print, like page 27, it's like, by the way, we're going to take your DNA. That's going to go to a third party. They can use that against your insurance. You can be turned down for your insurance in the future, et cetera, et cetera. And the doctor was surprised that I wouldn't do the program. And I explained that, and she had no idea. And I thought, okay, I can never do a UCLA study now. Are all the studies coming out with this, or is there a way to get around that?
Yeah, very important point. Did everybody hear this? Okay, so let me quickly, for those of you who haven't heard it, let me quickly repeat. Okay, so when you read some of the informed consent form and the fine print in the informed consent form, you may come across a section which talks about the storage and taking genetic material from you, i.e. DNA. So that's the genetic material, right? But that's not even the point. What's actually says in some of these informed consent form is, we take this material from you and we will store it, and we may make it available to other third parties for additional research. So let me address this from a research perspective for a moment, okay? When you remember what Dan talked about, he talked about the fact that a lot of these diseases, and mainly lupus, is driven by something that's going on in the genetic material, in the genes, right? And the DNA is the core material of our genes. So if we want to study a drug like Safnello, for example, okay, Safnello is a medication that targets a protein called interferon. Now, in order to understand how these medications work, we often have to study the genetic material of patients in order to understand why a patient may respond to Safnello or not. Now, so not every storage or taking of genetic material doesn't necessarily mean you're going to end up in some Russian lab where somebody doing some dubious. Okay, it may be really bona fide research and scientific research and approved research. But I hear you loud and clear. And by the way, for that reason, most, not all, most clinical trials have genetic materials included as a sub-study, as a separate informed consent. In other words, you can consent to participate in the study, but you do not need to do the genetic material part of it, or the local IRB. So what's the local IRB? Just as a quick reminder, I didn't talk much about it, but before, let's say you go to see your study doctor at, let's say, UCLA. Before that doctor at UCLA does that study, he or she needs to actually bring it to the local institutional regulatory board, okay, review board. And that's a group of people within UCLA that looks through the protocol and makes sure that this is all kosher, right? So unless these guys sign off on it, there will be no study. And a lot of these IRBs do not allow genetic material to be taken, okay? So they may say you can't do that, but I see your point, and if you're not comfortable with this, and I understand exactly where you're coming from, you should not participate in this clinical trial. Absolutely. End of the question.
What percentage of clinical trials have follow-up investigations to check in on patients and in general? And then are there more or less of those that offer that follow-up for lupus clinical trials?
Sorry, can you repeat this one more time?
Yeah, so the first question is, what percentage of clinical trials offer this kind of follow-up with patients after the clinical trial has ended? And then specifically for lupus clinical trials, are there more or less than those
Yep.
in general?
Good point. I'm not sure if I can quote you a good number for all indications, from anything from diabetes to thyroid and you name it, all these diseases. But in general, I would say probably a good 30 to 40% of all clinical trials offer this open label extension. For lupus trials, it tends to be more because we just simply want to establish the safety, the long-term safety, and what we call efficacy, the way it works or how good it works in these clinical trials. And I think the Benlysta example is a good example because people finally learned that they were burned by not including the right population. And so they studied this now very carefully and include it from the get-go. Now, you see this typically for phase 3 studies. In the phase 2 studies, the earlier ones where we're still looking for doses, there are a couple of designs. One is that you can, if you participated in the phase 2, some studies allow you to roll over into the phase 3 and participate again for another few years. And for those that do not, the number of follow-up studies will be less. So it's typically phase 3s that have these long-term follow-up studies. Good questions, guys.
Thank you, Dr. Wright.
All right, thank you so much.
It's my pleasure to introduce one of our newest medical advisory board members, Dr. Leanna Wise. Dr. Wise is a rheumatologist at Keck Medicine of USC.
Great. Thank you all for coming. I appreciate everyone showing up after lunch. I actually just spoke at a conference about 2 weeks ago, and I was the speaker right before lunch. And I was kind of joking that just speaking around lunchtime, I think is dangerous. You're either ready to go right to lunch, but then when you speak right after lunch, everyone's kind of groggy and sleepy right after lunch. So hopefully you guys are well fed, but not too well fed. So we'll be speaking today on nutrition and lupus, and I call this an evidence-based approach. And this title here is really key. When I say evidence-based, I'm going to be going based on scientific evidence. So what kind of studies, what kind of data is out there so far? And this is really important. We as doctors in Western medicine, we really try to base all our decisions based on scientific studies that have been done. And, I take into account what my patients say. I take into account what I've, read online in, say, patient message boards, stuff like this. But this is really based on studies that have been done, which in lupus and nutrition are very, very minimal. So just kind of cutting to the chase there. There's not a lot of data out there. So I'm kind of distilling what is there, which is minimal, into this PowerPoint today. So let's go ahead and get started. And these are my disclosures. So our objectives for today, we're going to talk about the role of nutrition and how it can benefit and hopefully impact the life of someone with lupus. And just a few disclaimers, I'm not a dietitian. All of this is just my own research and what I've looked at online, tried to read about to the best of my ability, but I don't really have a background in nutrition. I have a background, I have an MD, I have a public health background as well. I know how to read the literature, but again, I'm not a registered dietitian. This is a degree that's like a 4-year bachelor's. You can do extra training as well. You can get a master's, and then you have to do a whole bunch of clinical, I think something like 1,000 hours of work. I didn't do that. So you guys might ask me a question. I say, I don't know. So just bear with me with that. And I'm also not going to cover other complementary therapies like, well, what's the role of exercise in lupus, or medical marijuana, or TCM, which is traditional Chinese medicine. And they use a lot of herbs and plants with traditional Chinese medicine. I have reviewed the literature with some of these, but again, I'm not going to cover it for the sake of this talk. It would just take too long. I'm also not going to talk about vitamin D supplementation with this talk. I'm going to be focusing mostly on human studies, not mouse or cell studies. So there are some studies where we look at mice with lupus, or we take the cells or the blood of patients with lupus and we introduce them to like diet products or dietary supplements, and we study those. But I'm really just going to be focusing on studies that look at how humans respond to certain dietary interventions or dietary supplements. Because that's real life, right? We don't really care like what, I mean, we do care how mice with lupus, you know, what happens if they eat blueberries or something, but I care about my patients, not necessarily like mice with lupus. Those aren't my patients. So these are questions that I'm asked in the clinic all the time. And I think you guys probably ask as well. And I even ask this. I see physicians also, and I will Google these things. You know, I don't have lupus, but I care about my family members, my mom and my dad who have issues, my own small health issues. I ask these questions as well. People say, what can I do to treat my lupus naturally, whatever that naturally actually means? There's this Lupa Vita or Lupa Vita that you can buy on Amazon, and people will say, can I take this? Is this okay for me to take? Is this a good idea? It has some vitamins in it, some turmeric and cherry extract. It's kind of expensive. It's like $50, $60 for 1 month supply. And they'll say, can I eat a certain, or should I eat tomatoes or red meat or fatty foods? They'll, you know, maybe read a certain author or a certain doctor will say you should or shouldn't eat this certain food. Or people will ask about a certain dietary plan. Maybe I should do vegan. Should I do keto or paleo? What about these diets? So these are very reasonable questions to ask. And again, I'm asked about these all the time for lupus, for rheumatoid arthritis, and other diseases. So a big thing I want to say that regardless of what we're going to talk about today, any sort of nutrition or dietary approach, these are complementary and integrative in addition to the medications we also prescribe. They go hand in hand. It's a partnership. They will never, ever, ever replace the medications we give. Now, maybe they'll help us, say, reduce some medications with time or avoid maybe hopefully using more steroids. I think we all know steroids are not the best medications to be on, but never, ever would I recommend, oh yeah, we can go the natural food approach. And that means that you don't need any of my Western medications or the medications I prescribe. So they go hand in hand. They can work very well together. I think a good example would be when someone says, hey, you have high blood pressure. Well, we can give you a blood pressure pill and you need to watch the amount of salt that you eat in your diet. That same idea. Or with diabetes, you might be on diabetes medications, but you also need to watch your sugars. So it's that same idea here. And again, before we get into our details here, I also want to point out that natural does not always mean safe. So in that first little list there, I have a list of things that are, in theory, natural. And sometimes you even use for good things. So people get Botox for migraines and also for beauty reasons. But if you inject Botox incorrectly, you could kill someone, you could paralyze them. Arsenic, snake venom, those are natural occurring substances. Those are not safe. These are plants that if you were to consume them, especially in high amounts, they could kill you, but we also get medications from some of these. Tobacco, coca leaf. This is a mint that can cause severe liver damage, and even just the sun. That's a natural thing, but that can cause sun damage, photoaging, basically, and even sun cancer. So just because something's natural does not mean it is unequivocally safe, and you can just go the natural route without thinking about it. And then on the flip side, I also like to point out that some of our drugs we use for lupus also have kind of a natural origin. So hydroxychloroquine has been around for actually millennia. It's a very old drug, and this comes from the bark of a tree. Tacrolimus, aspirin, and for some patients who are on opioids, these are all naturally found substances as well. So it's not just black and white. Either you're on a very synthetic Western medication or there's a very safe natural drug. I think that there's a big spectrum and there's a lot of gray areas. So I just like to discuss this with patients and make sure we realize that just because someone's on a natural medication or an herb that they found at Whole Foods or something, it doesn't mean that it's always safe. I'll go through these slides kind of quickly, but sometimes my patients and even my family members have asked, why don't we have a lot of studies with nutrition and rheumatic diseases? And I do like to point out here, studying nutrition is actually very, very hard. And I just like to go over this really briefly so people understand this is not something that, it's not that it's not being done because people don't care. It truly is very difficult to understand how nutrition interacts with our bodies and to do a really good trial in nutrition. There's really 3 reasons for this. Designing a nutrition study is difficult. So the way the study is designed, Enrolling certain patients in the study is difficult. And then lupus patients are very complex, as you guys know. And then even what we do with those results, it's difficult to say, how do we extrapolate those results? And I think one example here is, I'll just give one example for number 2. Let's say we were to design a study for pharmaceutical companies. One set of patients might get the medication, the other patients get the placebo, a fake pill basically, or a sugar pill. You'll get your normal lupus medications, but one group of patients, they'll get that placebo pill. How do you do a placebo in nutrition? You can't. If you tell this group of patients, okay, you guys are going to eat a lot of, I'm going to use blueberries as an example. You guys are going to be taking your normal lupus medications and eating a whole bunch of blueberries. How do you have placebo blueberries? You can't. You just have an arm of patients where you say, don't eat blueberries. And so you will always have a group of people where you know this group of patients, they did not get what we call the intervention. And I'm getting kind of into the weeds here, but essentially these types of studies in nutrition end up being extremely different than what I would call normal drug trials. And they just end up being a little bit lower or a lot lower quality. So we have a hard time saying that the types of studies we see in nutrition are very different than pharmaceutical drug trials. And we also probably need a lot longer length to study nutrition. Probably studying nutrition for 4 weeks, 6 weeks, 24 weeks is not adequate. We probably need years and years to study the effect of nutrition on the body. How was our nutrition as a child, as a teenager, 20s or 30s? That also plays a role, and that would be very expensive. So nutrition studies, again, very complex, and it's not quite the same as just giving someone a pill for six weeks, 6 months, something like that. So really the end result is, like I kind of mentioned at the beginning, we just don't have a lot of studies looking at nutrition and lupus. I would say that it does seem like there was some interest starting to rise. The pandemic kind of squashed this interest. I did actually have a friend who was involved with a study at Loma Linda right when the pandemic started, and they basically couldn't recruit patients during the pandemic, so that was unfortunate. And ultimately, like I said, we just have to be careful with the conclusions. If somebody says, you know, we gave patients organic blueberries for 6 months, they got better. What about non-organic blueberries? Would non-organic blueberries have the same effect? Would miniature blueberries have the same effect as large blueberries? You know, there's all types of blueberries. Do we have to use that exact same type of blueberry? Not all blueberries are the same. What about ones grown in December versus June? Ones from North America versus Europe? So you can see how you can get into the weeds here. And you actually have to be very careful with extrapolating results from nutrition studies. So I know I sound like I'm being very negative here about food studies, but when we evaluate trials as doctors, we do get very bogged down in details. Okay, so at the end of the day, why do we care about the role of nutrition and rheumatic disease? Well, we just care. I mean, people are making decisions about nutrition every single day, multiple times a day. I mean, we were out there eating lunch. There's lots of cookies on the table, muffins, you get a box of food. On your way home, you're wondering, should I stop for food? Every single day, we're making multiple decisions about nutrition. This is something we care about in our everyday life. Medications are great. They control lupus disease activity, but patients still have symptoms. Fatigue, poor sleep, weight gain, things like these. Can we prevent other problems as well? So high blood pressure, diabetes, cancers even. This idea of something called secondary or tertiary prevention. If patients are eating really well, can they stave off things like I mentioned, like heart disease or certain cancers by eating well? Maybe these are not directly lupus related problems, but they're tied to lupus, and eating really well can prevent some of these. And then finally, again, why do we care about nutrition? If you were to walk down the Whole Foods supplement aisles, these are actual pictures of dietary supplements. Even when I walk down my Whole Foods, I kind of like look at these and wonder, and I'm looking at all of these and I think, oh, this is children's, but you know, there's things that say joint support and immune system health. And I definitely wonder, like, what is in all of these? What is going on with these? I need to read about these, because if I'm wondering about all of these, for sure, everyone else is too. So sometimes I'll just pick up a bottle or two and look at the ingredients and say, okay, I'll try to think about this and read about it. You know, new natural products and children's health. I mean, there's so much out there that this should kind of pique our interest, and we should know what people are picking up and looking at and perhaps taking. And I found that a lot of my patients will take some of these and not always tell me. So I try to probe and ask, you know, what have you tried? What are you taking? My husband is really big into these like green foods right now. And I said, what's a green food? Why don't you just eat the green foods? Why do you have to take a powdered green food? Just eat the green food. Okay. All right. So let's get into lupus and nutrition. With all that aside, lupus is such a diverse disease, as we all know, as you guys have talked to each other, as I see my patients. The immune system is faulty at many points with lupus. There's so many different cells involved. Because of this, even really big promising drugs can fail in some trials. We see these trials that in their preliminary studies, they look so good, but when they go to their third phase of trial, they fail. They don't do as well. So we have patients at the end of the day who have a lot of persistent symptoms. We say this is unmet needs. Pain and fatigue especially are persistent in our lupus population. So we see even when you treat patients really well and their disease becomes quiet, their lupus becomes quiet, sometimes pain and fatigue still persist. And I'm sure many of you guys could attest to that. And these are not always associated with medications. So we could give more and more steroids or more Benlysta or more X, Y, or Z, but for some reason, still a lot of pain and fatigue persists. So what could we do? Is there anything we could continue to do or add that would help with things like pain and fatigue? And no study in nutrition could be, or no presentation on nutrition could be complete without talking about obesity as well. So I am going to have one slide on this, but we're not going to focus on obesity and weight for the majority of this. But because obesity is linked with nutrition, I do want to point out here that when we look at patients or populations with lupus and obesity, we do see that it's linked to worse quality of life. So this is things just when you ask the patients, like, how is your life going? How is your sleep? How is your emotional health? How are you just feeling like life is going? Generally speaking, higher obesity is associated with worse quality of life and more lupus symptoms too. There's also a higher risk of vascular disease. So these would be things like strokes and heart disease with patients who are obese. But exercise can actually help with disease control. And I know I said I wasn't going to talk about exercise in this, but this is the one little snippet where I will. Patients will ask, well, what sort of exercise should I do with lupus? Your joints are hurting. So I wouldn't usually say, do not go out and run a 5K or a 10K. I would say whatever you enjoy and can do, and that generally builds up muscle. Whatever you like to do in terms of movement. It could be Pilates or swimming, gentle movement. Any type of gentle movement is good. The goal is not to rapidly lose weight. The weight loss literature is very clear that anyone who rapidly loses weight will gain it back. So the last thing I want you to think in terms of takeaways from this slide is that I'm saying you have to rapidly lose weight. Even if you're just moving without weight loss, if you're building muscle, this is a good thing for lupus, especially when you're on steroids. So I really just want to point out here, my takeaway from this slide is do not rapidly lose weight. It's build muscle, move, be active. Whatever type of exercise fits with you and your lifestyle, that is good. And I'm also not saying stop your steroids immediately. I'm just saying, talk with your doctor about what other drugs you could use to possibly replace steroids. We encourage a healthy weight. Steroids usually don't contribute to a healthy weight. So talk with your doctor about what other drugs could potentially replace steroids. So healthy weight is important, but what kind of eating plan or diet should lupus patients consider? I put this picture up here because I love raw cookie dough. And I know how hard it is to eat healthy, especially when you're on steroids. So I know we're going to talk a lot about eating healthy, and it's so much easier said than done for me as well. All right. I'm going to set the stage for what we're going to talk about in the next several slides, and then we're going to talk about this again to wrap up. But essentially, the very limited human studies we have, and this is kind of a key thing here, and this is also backed up by many mouse studies, but again, we're focusing on human here, show that a diet high in polyphenols, and we'll talk about what these are, and omega-3 fatty acids may help to naturally treat some lupus symptoms. This would be very well wrapped up in this idea of a Mediterranean diet. Again, we're going to talk about what this is. So let's go into this more in depth. Okay, so this is kind of a key slide. Again, we're going to talk about what polyphenols are and where to find omega-3 fatty acids, which are very commonly known as healthy fats for some. So polyphenols are what I call God's or nature's anti-inflammatories. And these are naturally occurring chemicals that are only found in plants that fight inflammation. So again, these are just found in plant products. You do not find these in any animal products. Fruits, veggies, spices, and herbs in particular, very, very high polyphenols in spices and herbs. Tea and even wine These are all items that are very high in polyphenols. And the way I think about polyphenols, these chemicals in particular, they give plant products their strong colors, taste, or odor. So even a white onion, which doesn't have a strong color, it does have a very strong taste or odor. So that's very, very high in polyphenols. You can see a lot of different colorful foods in here: pomegranates, grapes, even dark chocolate, berries. This would be, I guess, matcha tea down here. But all the other, again, I want to go back to spices and herbs: cloves, cinnamon, turmeric. Any spice or herb you can think of is extremely high in polyphenols. So I really impress upon my patients, as much as you can throw salt out for seasoning, get rid of your salt and throw on spices and herbs for seasoning, fresh or dried. You don't have to just buy a whole bunch of fresh herbs and spices every day. The dried ones are fine too. And I think some nutritionists think they might actually be a little more concentrated. So again, I'm not saying you have to go to the grocery store every day just to buy fresh herbs. That's very redundant. But dried is just as fine. So again, I have some examples here. And the nice thing about spices and herbs is, kind of regardless of your ethnic background, a lot of different cultures have lots of spices and herbs in their dishes. So it's not like, oh, I can only cook like, you know, a certain way of eating. Like, just, you really could find any type of spices, any types of herbs, and start throwing them into your dishes. And you just Google polyphenol containing foods and you're going to find so many, but really any fruits, veggies, spices, herbs, and again, wine, and also dark chocolate is very high in it. Omega-3 fatty acids. So these are considered kind of the healthy fats. These also lower inflammation. These are found in cold water fatty fish. Salmon is really very, very high in it, probably the highest, and also nuts and seeds. And this has also been linked to very good heart and brain health. As I mentioned, salmon's probably the highest, but you can also find it in anchovies, sardines. And then for people who are vegetarian or vegan, you can also find it in walnuts, chia, and flax, but it's at much lower amounts. So really, like, the best bang for your buck is actually in salmon. So I encourage people to eat salmon if they can. I know a little pricey, but omega-3 is very, very high in salmon. So if someone's saying, well, I don't really eat a lot of fish, I do like it, I would say if you're going to eat some sort of animal protein, I would really like it to be what I call a cold water fatty fish. But you can sprinkle walnuts, chia, flax into oatmeal. Again, chia and flax go well with a lot of things. You can, again, put that in with like your spices and herbs into stuff, cook with that. Very, very good for fighting inflammation. So let's get into some of the data. Again, incredibly limited when this comes to lupus. So I'm going to show you what's out there, and we'll go into this just very briefly. So in Iran, there was a very small study looking at a set of humans with lupus nephritis, just 24 patients. And they gave these patients some curcumin or turmeric. So this is the spice that you would find in a lot of curry dishes. They gave them some curcumin supplements in addition to their standard lupus nephritis treatment. So again, this did not replace their lupus nephritis treatment. They gave them their normal standard of care treatment. One group got curcumin or turmeric, and then one got placebo capsules of curcumin. And the patients that got the curcumin group, or the group that got the curcumin supplement, actually had a better improvement in their protein levels in their urine and blood pressure after, I think this was only 24 weeks. So that was a good thing that they saw. This is overall quite safe. It's been studied at higher doses in cancer patients, maybe a little bit of acid reflux, but overall a very safe supplement. So I encourage my patients with lupus or lupus nephritis to cook with this as much as possible. And again, this is kind of going back to this idea of polyphenol-rich foods being very helpful in lupus, and turmeric is very high in polyphenols. This has also been backed up with many mouse model studies. There was a single mouse model study where it showed it was not beneficial, but all the other mouse model studies, it was. There was one study, again, out of Iran. They're very like supplement friendly in Iran, so they fund a lot of these studies. This looked at green tea extract in lupus patients. The caveat to this one is that the lupus patients in this study already had really quiet disease. It was very well controlled. These were not rip-roaring lupus patients, but they had a little bit of active disease, some enough to get into this study. They basically gave them a green tea supplement, and they saw that that little bit of disease that was active was better controlled over time. And again, I think this was also about 24 weeks, about half a year. Might have been even a little less. I think this might have been less than half a year. And they also saw that this improved quality of life, particularly as it relates to fatigue. And I have a feeling that was the caffeine talking from the green tea. So that's fine. If you feel better, if your fatigue is better, that's fine. My only concern with this is I don't really like people taking the green tea extract. I would rather have them just drink the tea or take matcha, okay? So please do not go buy green tea extract on Amazon. There are associations with liver failure with purified green tea extract. Matcha is not green tea extract. It's a certain way that the green tea is grown and then harvested, like under the shade or something. I don't know. It's just not extract. So don't buy a green tea extract. Drink matcha or drink green tea itself. This is just like normal stuff. Don't buy like a really purified extract. But regardless, the little bit of lupus disease activity did improve in this study. Green tea, again, is very high in polyphenols. So moving on to fish oil supplement, this was actually a really interesting study out of China. This was looking at lupus nephritis patients where they added the fish oil supplement to what's considered standard of care or one form of standard of care for lupus nephritis patients in China, which was cyclophosphamide. And the patients who got the fish oil group, fish oil supplement instead of placebo, actually had better response to the cyclophosphamide. So their protein in their urine went down to a greater degree. And then interestingly, they also had less side effects, especially as it related to urinary tract infections. So this I thought was actually a pretty well done study and actually had a pretty good amount of patients. But the biggest problem with this study is these patients didn't have very large degree of protein or very bad lupus nephritis to begin with. So they weren't as sick as some of my own lupus nephritis patients that I treat, but I still like that this looks like it's very anti-inflammatory. So it's going back to that idea of omega-3 fatty acids, at least as a fish oil supplement, appears to be anti-inflammatory. And then looking back at the literature as a whole, there was something called a systematic review where it takes many studies and groups them together and tries to do some like a good synthesis or some good statistics and looks at fish oil. What does this do in lupus? And overall, the conclusion from 13 trials with this giving fish oil is largely neutral or positive. And in the way that it was positive is that it seems to have good effect on what we would call patients' subjective symptoms. And these are the things that you and I care about, the things that affect quality of life, like pain, fatigue, overall well-being, just how you generally feel when you get through the day. We're not talking about necessarily lab markers like double-stranded DNA or complement levels or your white blood cell count. We're talking about the things that patients feel when, again, during your waking hours. So I think that's really important because like I mentioned a few slides ago, your lupus might be well controlled, but if you're not feeling that well, like it's great that your lupus is controlled. Yes, that's good. But what other things can you do to help get rid of some of these annoying symptoms? I don't always recommend that someone is taking a supplement. I would rather the patient eat in a healthy way. So that is my caveat to this slide. I don't always say, oh, just throw a whole bunch of fish oil supplements on, you're going to feel better. Eat the fish, eat in a healthy manner. But I do like that this review said a high omega-3 intake is associated with better symptoms. And this was a cross-sectional study that was associated with a similar result. So again, this can kind of be wrapped up in this idea of a Mediterranean diet, which I'm going to go to a little bit on one of my last slides. But the Mediterranean diet has been linked to a couple groups in southern and mid-Italy. And this is a diet that's very, very high and rich in plant intake and omega-3 fatty acids. And a study showed that patients who ate a lot of a Mediterranean diet had better lupus control, less steroid use, which is great, and overall better heart health. We'll talk about what Mediterranean diet might mean for us in a bit. So ultimately, all these studies are great, but how do patients actually think and feel when they eat a certain way? And I even have asked my patients, how do you think your nutrition interacts with your lupus symptoms? So there have been a few patient-reported surveys asking, you know, how does nutrition interact with you? Like, what do you think about food and your lupus? So there have been 3 surveys done so far, and across the board, it's been very striking how patients have reported their symptoms. Surveys we have to be careful with because there's something called response bias. Generally, people who respond to surveys are a little more gung-ho about their care. They actually feel like, oh yeah, I'm really interested to talk about nutrition. People who don't respond to surveys might be a little bit like, nutrition has nothing to do with me. I'm not going to respond. So there's a little bias, so just keep that in mind. But with these surveys, there's definitely a very clear response that patients feel that their lupus is better with fruits, vegetables, tea, and fish, and overall worse lupus symptoms with red meat, junk food, dessert, and processed food. And then our clinic here at County, which would be somewhere over here-ish in this little building. We did the same type of survey in 300 patients at our outpatient rheumatology clinic, and we saw same results in our primarily Hispanic population. So again, this is consistent with all the literature that I just presented, right? Fruits, veggies, tea, and fish. We did see some patients say that they thought spices and herbs might actually worsen their reflux, which I think makes sense maybe for some people. If you're doing like a lot of like chilies or salsas, that maybe would worsen the reflux part. So I think that might be kind of equivocal. So in summary, our limited human studies that we have so far, but this is also backed up by mouse studies, show that a diet high in polyphenols and omega-3 fatty acids can treat some lupus symptoms. Polyphenols and omega-3 fatty acids, this is basically something I would recommend through eating a lot of whole foods, a plant-based diet, lots of fruits and veggies, lots of spices and herbs, fatty cold water fish, and then also a lot of nuts and seeds if possible. And then just some final thoughts and questions that, patients will ask me as a result of talking about these things. I think this one's very key. Should I take a supplement to get these things, or should I eat the whole food, particularly as it relates to something like omega-3s or say turmeric, which I've talked about already? I would generally prefer patients to eat the whole food and to incorporate that food into their diet. I guess some of the good things about supplements is they're generally they're supposed to be just the item that is being sold, but there is no regulation of supplements, little to no regulation with some exceptions. There can be fillers in the supplements that the company does not have to report. And unless there is a complaint filed against that supplement, and I think it's the FDA, there might be another group that also will look into it, no one really has to like police the supplement company. So they could put all sorts of stuff into the supplements, and there can be huge variation from one batch to another. So I'm not a huge fan of people taking a supplement because we don't exactly know what is in it all the time. Is there anything extra? Is there as much as the company says is in there? So I'd rather have you just, if you're going to take turmeric, just buy a turmeric root and try to shave that thing into a whole bunch of soups or whatever. Eat the salmon, eat a whole bunch of berries, eat a whole bunch of fruits and veggies, and it will also fill you up more, and you'll tend to start eating a very anti-inflammatory diet rather than a pro-inflammatory diet, which would be lots more processed food. So there's pros and cons, but generally I recommend that people actually eat the food rather than the supplements. And you're also, once you're doing that, you're getting benefits for other things too: blood pressure, cancer prevention, hopefully maybe some weight loss if needed. So I usually tell my patients, you can't use supplements to like outweigh a poor diet. So if someone's eating poorly and then they're saying, well, I take a whole bunch of fish oil, I take like a baggie full of supplements, that does not outweigh a poor diet. I have seen that happen. I have friends who do that. Okay. They bring a baggie and we're going out to eat and they get like a really, I don't want to sound judgy, but it's like not a healthy meal. And then they have like a baggie of supplements. I'm like, that's not how it works. And then finally, I also want to think, if you're going to eat a certain way, is that sustainable? Like, can you do this literally for almost the rest of your life? You should be eating a certain way, fairly healthy for 80-90% of the time. Is that sustainable? Can you do that most days of the week? Yeah, have your raw cookie dough, have a piece of cake here and there. Like, don't go crazy, but is that sustainable for you and your family in the long run? Is it logistically doable? Can you do that when you're at work, on the go, etc.? So in summary, load up on fruits, veggies, spices and herbs, fish, other sources of omega-3. Tea is fantastic. I'm a huge fan of tea. I just also don't like coffee, so I have to drink a lot of tea. Wine is probably okay. I would say do avoid it if you have a history of alcohol abuse, and you probably have to minimize it if you're on certain medications. Consider asking to see a dietitian or nutritionist. Like I said, I'm not a dietitian and probably no other rheumatologist is. So get plugged in with a dietitian if you want more information. Try to move, be active, and maintain a healthy weight. Again, all these dietary things need to be sustainable and doable for you as an individual and your family. Because if you're trying to cook 2 meals or 3 meals, I mean, I have 2 kids and sometimes I am making a separate meal for them and it's such a headache. And so if you have to make your own meal and your kids or your spouse or your significant other says, I'm not going to eat that, and every single day you're having to make extra meals for people because they're not eating what you're eating, something has to change. Again, nutrition never replaces our medication. It's complementary and it's integrative. It can help. Maybe it can help minimize some medications long-term, but it's never, ever going to replace what we're also prescribing. I also think that healthy eating is probably going to be most effective before the lupus is active. So when you're having a severe flare, again, this is not going to replace needing steroids and needing certain medications. And there's the same idea with other diseases. If someone has, God forbid, stage 3 or 4 cancer, I would never say, oh, just eat your way out of the cancer and be, nutritionally conscious. You have to get chemo or whatever's needed. A couple good resources. So UCSF Osher Center for Integrative Health has this wonderful page on nutrition and lupus. Shameless plug, I helped to write this page, so you'll see my name at the end of it. But this actually is a summary of everything we talked about today, maybe a little more in depth, but this is a really helpful page. So again, UCSF, if you just Google nutrition and lupus, this is actually one of the first things that comes up on Google. So UCSF Osher. And then I really love this website. You can actually find it through the American College of Rheumatology as well. This is a website that actually distills the Mediterranean diet into culturally appropriate diets. So it's called Old Ways. I don't know where Old Way, I guess Old Ways kind of is talking about like the way that all cultures used to eat before things kind of got industrialized and commercialized. But essentially, let's see if it comes up well here. Yeah. So what it does is it takes the Mediterranean diet and it makes it more culturally friendly to all ethnic groups. So that way, when you tell someone from, say, Oaxaca, Mexico, way southern Mexico, oh, you got to eat the Mediterranean diet. What does that mean to them? That means almost like nothing to some people. Like, I'm not going to eat a Mediterranean diet if they're from deep southern Mexico. They're not ethnically Mediterranean. So I like this section in the Old Ways website that just calls it traditional diets. And it actually takes this idea of a Mediterranean diet, which again, very plant-based, very high in healthy fats. And it breaks it down into what's kind of more like culturally appropriate dietary patterns. Mediterranean diet, it does start with something called African heritage diet, Latin American diet, Asian diet, and then it has like a vegetarian and vegan diet that's full in healthy foods. I do have some vegan patients that all they eat is like processed vegan meals, and that's not healthy either. So if you are eating vegan, you have to make sure that you're still eating very healthy vegan dietary patterns. And then even on this website, there's all kinds of wonderful ways to eat anti-inflammatory foods, lentils, garlic, bulgur wheat, which is it's like salmon, like all kinds of really creative ways of eating. So I really like this website and just having it just helps people kind of eat more creatively and introduce a lot of anti-inflammatory and polyphenol-rich foods that we've talked about. So I recommend people checking this out. And I think there's some good resources even for getting plugged in with dietitians. All right. I think we're doing pretty good on time. Any questions?
I thank you for another excellent presentation, but I drink a lot of green tea. I'm just not sure if I'm drinking too much or too little to get the health benefits. Is there a recommendation on how much to intake as far as green tea?
There's no lupus data that says what the recommendation is. It would be very hard to overdo it. There have been studies there have been case reports that have looked at people who have drank like literally liters, and that's too much. Are you drinking liters?
That would be a no.
Yeah, I would not say liters. If you're drinking a couple cups a day, again, there's no clear amount that people should or shouldn't drink for lupus. If you're drinking a few cups a day, I don't know if that's enough. We aren't sure how much is a good amount. I would say it's kind of like the overall idea of, replacing soda with green tea. If you're thirsty and you're saying, look, I want something other than just water to drink, green tea's an idea. Matcha is really good. Matcha is very high in polyphenols. That's something you might want to consider. But there's no clear like, oh, you need to be drinking exactly 7 bags a day. There's no answer from the lupus literature, unfortunately, but it's a very hard thing to overdo. There are case reports of people doing like, again, like 100 bags a day. That's too much, but a few bags you're not going to overdo it if you're doing, 5 to 8, or you switch to something like matcha, which might actually be a higher concentration of the polyphenols.
Yeah. Oh. I mean, I just eat a all around healthy diet, but I've been reading more about, sugar contributing to inflammation. So do you think that someone who has lupus should limit their sugar intake? Is this really true or?
That's a great question, and that's hard to answer. So even when we say what is sugar, there's many types of sugar. So sugar is just a carbohydrate. So a carbohydrate is many things, and you can find sugar in, say, berries. So a extreme example of limiting sugar is a ketogenic diet, and I would not recommend that. Now, I think when a lot of people say sugar, they're thinking of things like processed sugar. Is that kind of what you're referring to? Yeah. So I would say as much as possible, any person should try to limit sugar. So cake, cookies, soda, yes, we should limit sugar. That's just like a general recommendation that any clinician would recommend. And I think if you have an autoimmune disease, that's even more important. That being said, I'm like just a proponent of still enjoying life. And if on the weekend you're at a birthday party, having a slice of cake and still being reasonable and celebrating life with your family and friends. But I would not have processed sugar every single day. And I think a lot of my patients, and even these surveys that I mentioned at the end, consistently, hands down, one of the things that was marked as in terms of subjective lupus symptoms worsening was processed sugar. Now, when you think about naturally occurring sugars, again, which are present in fruits, those are to me, that's fine. And there are so many anti-inflammatory components in whole grains and fruits that I would not limit those. So I would say you can load up on the whole grains and fruits.
For an individual who eats salmon 2 or 3 times a week and also takes omega-3 supplements, are there too many supplements to take, or is there a limit?
There's some thought that omega-3s could interfere with blood clotting. That hasn't been definitively proven in humans. If you were to need surgery, a lot of times surgeons ask that you stop the omega-3 supplements. But especially if you're just eating a lot of salmon, people who eat a lot of salmon, that hasn't been linked with poor surgeries or a lot of bleeding. But if you were to have a surgery, they would ask that you would stop the supplements. But if someone wants to take supplements that eat a lot of salmon, I would say go for it. But again, I would be very open with your doctor about the amount of supplements you're taking. I can't say what is the exact amount. From the studies in lupus and rheumatoid arthritis, it's about 3 to 5 grams of omega-3s a day. So I would not be taking literally, I have patients who are just taking bagfuls of things, and that's not what I would recommend. Mhm.
Okay, we're going to come back to, yeah.
I recently read about prunes for bone health and osteoporosis. Can you comment on that?
I don't know, but I wouldn't be surprised. There is some osteoporosis literature showing that, and I think it's mostly cross-sectional. So we kind of have to be careful with cross-sectional type of literature for a couple reasons. But I know that there's some associations between also polyphenols and decreased risk of osteoporosis. And prunes are high in polyphenols. So I would not be surprised. Again, this is just an idea that people who are eating a lot of polyphenol-rich foods are overall healthy. And you see that in more things other than lupus and rheumatic diseases. So I don't know prunes specifically, but I would not be surprised.
Along the lines of nutrition, any studies that talk about gluten specifically with regard to inflammation and or allergies and their effect?
Not with lupus, but with a small subset of psoriasis patients, it might be a good idea to avoid gluten, but not with lupus that I'm aware of. Yeah. Now, some patients who cut it out and feel better, I would say go for it, but it's not a recommendation I would make across the board. If someone wants to experiment around with it, again, I'm okay. But the key thing comes down to sustainability. And that person, if they say, hey, I feel 50, 80% better off of gluten, and say, okay, you then need to avoid gluten the rest of your life. But I don't think there's any evidence to say that that gluten would be the culprit for the majority of patients with lupus. But there is a psoriasis group that would do better off of gluten. That's the only data we have.
Question on, you mentioned dried herbs are good. What's your take on dried fruits?
I don't know if I have a clear one. That's a good question. Probably, I don't know. That's more of a dietitian question. Probably fine. I don't know. I'm gonna punt that to maybe you should see it. I think largely okay. I mean, there's just really all you're doing is eliminating water. So I think I would say fine, but I would just say the more of a dietitian. Actually, kind of going off of that, smoothies are also that's I'm gonna segue actually to another thing is smoothies. So people who juice a lot and smoothies. That's actually something I want to be a little more careful with. You're actually reducing a lot of fiber when you take smoothies and juices. So that's something I feel a little more strongly about. So people say, oh, I juice a ton. You're actually eliminating a lot of fiber, which is really nutritious. And it actually can kind of mess with gut transit. And you're actually you're still getting some benefit, but I'm a big fan of eating whole, fresh foods. And dried fruit is probably just a notch under that, but it's probably fine. But again, that's something I would ask a nutrition or dietitian. Yeah. Definitely better than a smoothie. Smoothies are fun. But another thing about smoothies, you got to make sure they're not adding ice cream to them. Like Jamba Juices just adds ice cream and sweetened yogurt. You got to be careful with nutrition labels. Like there's so much sugar in yogurt and it looks like, oh, this is so healthy. But yeah, you got to be careful with nutrition and smoothies.
Hello. As a person without lupus, how would I incorporate, or what would be the first meal that I should create for my partner, if they're not used to the
Polyphenols?
Yeah,
Yeah.
polyphenol diet, if they're not used to that.
I would say like a good place to start. So I would say talking with a nutritionist would be a good step to kind of create a dietary plan and say, hey, I was told that these things are good. We're not really used to eating this way. The website that I mentioned on the last slide is really helpful. Probably just starting with like resources or recipes. But I've always found even for myself personally, but even for patients, like oatmeal is a really good vehicle to throw in stuff and kind of hide things. And for my kids too, who are picky eaters. So steel cut oats in particular, not the quick cook oats. They have a lot of times like Quaker oat packets have tons of sugar added, but steel cut oats, really high in fiber. You can put in flax, chia, cinnamon, nutmeg, cloves, which are like cloves are, I think are the highest bang for your buck with polyphenols. You just need a small dab of them. Again, the flax, chia, you can get some omega-3s there. And that will fill you up for a long time. But I think oatmeal is kind of nice because you can throw in a lot of things, a little bit of maple syrup to make it sweet. And then you can just kind of hide all these other spices and stuff and make it fun. But I would definitely, that's where a good nutritionist would come into play and say, hey, how could we make this person's meal plan fun? Because you don't want to say like, I just hate eating this way. It's so different than what I'm used to. Again, this has to be sustainable long-term.
Hi, is this on? Yeah. So how do you feel about water consumption and lupus? I always drink a lot of water, but sometimes I think I might be drinking too much.
I would say drink to thirst. If you feel thirsty, you should drink. Other people say you should be drinking so much that your urine is clear, but some people are taking vitamins and your urine will never be clear.
Right.
So you don't want to be drinking, oh my gosh, my pee is yellow, but that's just a B vitamin effect. And if you're taking some multivitamins, it will just always be yellow. So I don't want you to be so, peeing all day and all night. And now you're not sleeping well. And now you're fatigued all during the day.
I was kind of under the impression, I'm not sure if this is true or not, but I really upped my water consumption once I was diagnosed with lupus because I was taking so many meds that I was trying to like just not clear them out of my body because they're obviously working. The meds are working, but it just seemed like it might be better for the.
There's
have
nothing.
more
I
water.
mean, if you feel thirsty, I would drink. If you don't feel thirsty, I would not drink.
Okay.
There's nothing that says you need to be excessively hydrated. When you're on steroids, you may have a little water weight gain. I would not go overboard just for the sake of drinking water. You know, I think in general, a lot of people don't drink enough water. So you could probably err on the side of, okay, I'm going to drink, but it sounds like you're very cognizant of that. And generally we say drink to thirst and have some water next to you, sip it, but I wouldn't go overboard. There's nothing that says that lupus patients need to drink excessive amounts of water, especially if you have some kidney issues. You have to be very careful with, you know, your salt and water balance. So I would generally say drink to thirst. And that means if you feel thirsty, drink. If you don't feel thirsty, don't drink.
I have a question over here to your left.
Mhm.
Any thoughts or opinions on farm raised versus fresh caught salmon?
My dad has a lot of opinions. Yeah, I don't know. I actually, you know, I always heard that like the fresh caught was more ethically appropriate and better. And I don't remember the argument, but like 2 years ago, I heard someone argue for farm raised that was really compelling. And I don't even remember what that argument was. So obviously it wasn't that compelling, but I don't have great thoughts off the top of my head. If someone does not eat any salmon at all, I would say then at least incorporate salmon. If that happens to be farm raised, then so be it. It's kind of the same example to me that if someone says, well, I can't eat vegetables because I can't find organic vegetables. It's like, just then eat the non-organic ones. It's like, if the limiting factor is that you can't eat the salmon because you can't find the fresh caught or wild caught, then I don't know, that shouldn't be the limiting factor. But yeah, it's not something I've looked at super recently.
Hi, thank you for the information. And I really like the part about the wine. So
Yeah, most people do.
with that being said, with white or red, is there a better option between the two?
Generally red is higher, but even white and even beer has polyphenols, but red is higher in the same way that salmon is higher than like cod and walnuts, but they all contain omega-3s. Red is the highest. Yeah. Mm-hmm.
Take the last one. Right behind.
There's someone up there. Yeah.
That last question.
Hi, have you had patients benefit from the autoimmune protocol?
I knew someone would ask that question. Yeah, I've never actually had a lupus patient do it though. I've had other disease states do it. I'm okay with patients trying it. I don't recommend it because it's very stringent. So just for other people who, I don't know the autoimmune protocol in depth, but it's basically a really radical elimination diet. You take out a lot of inflammatory foods, which is pretty good. I do recommend that people don't eat a lot of inflammatory foods, like, you know, a lot of white bread, pastries, stuff like that. And then eventually they reintroduce some foods. It's not sustainable for most people, but from my understanding, it wasn't meant to be sustainable. You do introduce a lot of foods. And if someone wants to try it, I think it was originally developed for multiple sclerosis, which is not disease that rheumatologists treat, neurologists treat it. And I'm okay if patients want to experiment with it, but it's pretty radical. And I think you can get a lot of benefits through being less radical. And again, if you're eating that way, can the people that live with you eat the same way? I don't know. Again, I don't want to make multiple meals if I don't have to for people, or eat separately and then watch, you know, my kids eat a meal that looks really good and it's actually pretty healthy, but my protocol tells me not to. But I'm okay with people experimenting with it. Yeah. Yeah. Thanks for having me.
Our next speaker is Dr. Rahul Patel. He will be speaking on behalf of Impact Bio, one of our partners here today, and they're working on some exciting new research in the lupus space. Dr. Patel.
The slides. Oh, yeah. Okay, yeah. All right, thanks. All right, it's great to see a good turnout, especially on a Saturday, and the enthusiasm, interest. Hopefully, again, we've had some great speakers earlier. I'll give some further details, background about myself. So I'm a rheumatologist by training. I've been started out in academics, kind of similar to Dr. Reif, and then shifted into drug development, clinical trials. I've worked in not only SLE, but also a number of other rheumatologic conditions over the years. And fundamentally, it's quite an exciting time these days in lupus drug development in particular, with a lot of an exciting frontier evolving in the world of cell therapy, CAR T, that I'll touch on. So we've heard quite a bit from Dr. Wallace earlier about some of the background about SLE. In terms of therapies, traditionally we've thought of two typical areas of therapies, what are called small molecules. An example could be like Plaquenil or hydroxychloroquine, and even prednisone, steroids. These are medications you typically take as pills or sometimes as injections or infusions. Then there are biologics that are generally antibody-based proteins. Because these are large molecules, they are typically given by IV infusion or injections. Examples include anifrolumab or belimumab, Benlysta. And then there's an evolved area, a therapeutic platform called CAR T, or under the broader umbrella of cell therapy. And what is CAR T? Well, first of all, we are in Los Angeles, and a city that's known for its car culture. But when we say CAR T, we're not referring to car as in vehicle. Here, CAR stands for chimeric antigen receptor. And chimera refers to a Greek monster, Greek mythology monster that was composed of various different animals. Here, the CAR as a protein is composed of a mashup of different elements that basically lead to the T cell becoming a living drug. And as I'll touch on subsequent slides, this platform of CAR T has really revolutionized oncology, hematology oncology space, and we hope and believe that it has every potential to revolutionize autoimmune disease treatment. So why focus on the T cell? Well, we know that the T cell is a very important part of our immune system. It is naturally prone to be able to identify abnormal cells and attack cells that might have infections or other problems. So basically, as molecular biology evolved, we developed interventions that could turn this T cell into a living drug through insertion of this CAR gene, and basically leverage the inherent properties of the cytotoxic T cell. And the other key aspect of the T cell is that as a living drug, it can travel to any part of the body, including organs that have inflammation like the kidney, skin, et cetera, and wipe out the target B cells in this case that might be driving the inflammation, autoantibody production, et cetera. So again, the CAR T cell here depicted, you take basically a normal or a T cell from the patient's body and transform that with the insertion of this CAR gene to make it into a CAR T cell. And then the key target of these CAR T cells has generally been the B cells. There are antigens that are expressed on the B cell surface that make them very easily identified and targeted by the CAR T cell. One particular antigen that's been used in oncology and well validated is CD19. CD20 is another antigen expressed on a more limited set of B cells. There are biologics that are already shown to have effectiveness in conditions like lupus that target CD20. And our particular CAR T construct that we're developing actually targets CD19 as well as CD20, so a dual targeting approach. So this slide just kind of goes over CAR T, the history of CAR T. It is a relatively young therapeutic platform, but again, it's really revolutionized hematology oncology. Basically, the first patients that were dosed were only a little over 10 years ago, but there were, because of the transformational results identified and demonstrated, a number of commercially approved products are now available in oncology. And again, in drug development space in areas like lupus, a number of companies have jumped in to this area given the early some evolving proof of concept results. So as Dr. Wallace already mentioned, there's a number of steps involved in CAR T, so it's not as straightforward as being able to take a pill. But again, with the advances and the fact that thousands of patients now have been treated with CAR T, this has become a fairly streamlined process with key quality checks in place and ability to closely communicate to patients and doctors on the status of the manufacturing and predictability in terms of when the product will be ready. So again, there's several steps involved, starting with a leukapheresis collection, kind of like a blood donation, but where only the white cells are collected and the other elements of the blood cells are returned back to the patient. And then those white cells are sent off to a lab to manufacture into the CAR T product. And then that is eventually infused in the patient. There is a sort of what's called a turnaround time that where the patient is basically waiting for this product to be manufactured. But again, with advances in manufacturing process, that turnaround time can be as short as 3 weeks roughly. And again, part of that turnaround time is due to rigorous testing and other quality checks to make sure that the product is meets appropriate standards. So again, this slide just kind of goes over the various steps that are involved in creating a CAR T product, getting it back to the patient. And again, nowadays, the entire logistics, other quality steps have been well ironed out with experienced individuals, leading these efforts. So with any therapeutic revolution, there's a human element and story that is compelling and behind these developments. And two key patients that many might have heard of in the leukemia area were the patients of Emily Whitehead and Bill Ludwig, who were two of the first patients treated with CAR T at UPenn. And there's a documentary filmmaker, Ross Kaufman, who's made a documentary film primarily focused on Emily Whitehead's story that if you're interested, it's worth watching, called of Medicine and Miracles. So, but the bottom line is these patients were treated with CAR T. They had severe refractory B-cell cancers. They were given a single infusion of these CAR T cells, and their cancer was appropriately wiped out from these CAR T cells. And they were able to enjoy years of cancer-free life afterwards. And again, that type of transformational result really spurred dramatic development in oncology, and now a lot of effort underway to apply this platform to autoimmune disease. Just a few slides covering how these CAR T cells are manufactured in a manufacturing suite, and some of the steps patients go through. So the leukapheresis step, as I mentioned, it's kind of like a blood donation where the patient is hooked up to a machine that extracts the white cells from the body and returns all the other elements like red blood cells back to the patient. And then those cells, again, are shipped off, manufactured, and then the final transformative cells are basically in a very small volume bag that are infused back into the patient, generally as a single infusion. So what's really driven the excitement in lupus with this therapeutic platform of CAR T, a group in Germany started giving autologous CAR T treatment to severe refractory lupus patients and demonstrating transformational results, the type of results we have not seen with any other therapy to date. So all of these patients, the SLEDAI-2K is a validated measure of lupus activity. I found patients that had extremely high scores. They had multi-organ system involvement. All of them had lupus nephritis, inflammation in their kidneys. And after a single infusion of these CAR T products, all of their disease manifestations disappeared by 6 months. And this is an example patient that had severe cutaneous disease, subacute cutaneous lupus features. And again, a few months afterwards, basically all of her disease manifestations disappeared. She's smiling. As Dr. Reif mentioned, not only the assessment of the physician is important, but the patient's telling how they feel is important. And this group also measured components like fatigue. These patients had improvement in their fatigue scale. So again, this generated a huge amount of interest. They've so far treated 8 patients with this therapy, and showing in all 8 cases just dramatic responses, disappearance of their disease activity. These patients were able to wean off all their therapies, including prednisone, corticosteroids. And the first patient is now 3 years out from a single infusion and treatment. So we don't know yet how durable this may be, but again, the hope is that this could lead to an immunologic reset and a durable response. The other interesting thing is their B cells do recover and return over a period of time, but it's basically a naive B cell picture, basically with the B cells are not producing inflammation or autoantibodies, and suggesting that the immune system has basically been reset in these patients. Also important to note, the treatment was generally well tolerated from this experience as far as safety. So there are potential risks of CAR T, and obviously in a clinical trial setting, we want to closely monitor patients. In fact, we keep them hospitalized for a period of time, at least in the initial experience, to make sure that there are no significant safety events that come about. But in general, this experience with CAR T in lupus patients, there were some what's called cytokine release or some inflammation type reaction from these CAR T cells, but it was generally mild. And there was no significant neurotoxicity that was demonstrated. And there were a few infections, but generally typical upper respiratory type infections that were fairly mild in severity. Also, their protective antibodies, like from childhood vaccinations, were preserved because this CAR T approach that targets B cells spared the plasma cells. So yeah, we at Impact Bio, just as part of our history, we actually came out of UCLA, the research and efforts of Yvonne Chen, Tony Ribas, and some earlier work from Gideon Gross, and all that eventually came about to come up with Impact Bio as the biotech that exists today. We are based in the West Hills area, and with our state-of-the-art manufacturing here in this area, what Yvonne Chen developed in her lab is a sort of what you could think of as a differentiated CAR T product, where the CAR here recognizes two different antigens, CD19 as well as CD20. So any cell that expresses CD19 or CD20 would be targeted by these CAR T cells. Also, another key part of the CAR design is this co-stimulatory domain. The one that's utilized here is the 41BB. It's also the same CAR co-stimulatory component that was in the CAR product used by the group in Germany. And this CAR product that's under active study from our company was actually already utilized in a lymphoma study at UCLA. So an IIT, investigator-initiated trial at UCLA, and that experience showed a fairly well-tolerated safety profile. There was some inflammation, cytokine release demonstrated, but it was low grade, and there was no neurotoxicity. And these safety results were quite striking from the oncology experience, where, again, typically many of the competing products had much higher levels of not only cytokine release, but also neurotoxicity. And another key part of this product is that it utilizes a high concentration of central memory T cells. There's a ligand called CD62 ligand that is a marker for these central memory T cells. They have properties that are very beneficial for a CAR T product, including lower cytokine release, which may translate to the differentiated safety profile that I touched on. So we do have a trial that's up and running now. Again, UCLA is one of our key centers. We are getting other sites up and running. This trial will look for active proliferative lupus nephritis patients initially, and then expand to general SLE patients without the proliferative nephritis component. And again, we're excited to be part of this new frontier. Obviously, other companies are also part of this picture as well. And we'll have to see as data evolves and such. But again, we're excited about our product and feel that, again, it represents a differentiated CAR T product. And we're, again, grateful for the patients, their involvement and interest in being part of this exciting and pioneering frontier. And then just lastly, again, this particular strategy targets two antigens on B cells, CD19, CD20. As touched on earlier, there's no one size fits all in lupus. We feel that, again, this could be a compelling approach compared to just CD19 alone. And there is data that in active SLE, CD19 may be downregulated, suggesting that this dual targeting may have benefits and due to that phenomena. Yeah, so I know I went a bit over, but appreciate everyone's time and interest. Happy to take a few questions as well. Thanks.
Hi, thank you so much. My first question is, when do you expect the trial to move on from patients with nephritis to general SLE? And then also, for remission, does that mean no drugs, like zero drugs, total remission? Thank you.
Sure, great question. So the remission question, there are different definitions of remission. DORIS remission does allow low dose of corticosteroids, but you could modify those definitions. But yeah, the expectation is the bar we're hoping to hit is a patient having not only no active disease, but also the ability to wean off their background therapies, including prednisone, corticosteroids. Yeah. And then when we would expand into general SLE once we complete the phase 1 part of the study. So that again depends on patient recruitment and the number of patients we end up needing for that phase 1 part. But we're hoping if all goes well, again, to be in that phase 2 as soon as possible. Again, we have definitely a sense of urgency in trying to find these appropriate patients, get the study advanced to the phase 2 part. Yeah. So, I did also want to point out, as part of our study, we did get endorsement support from California Institute of Regenerative Medicine as well. They, understood the importance and potential of this approach. So, we did recently achieve that recognition. And again, we're excited to have their support as well in these efforts. Yeah.
So I know there's been box warnings for CAR T therapy for malignancies with future development of leukemia and lymphoma, but you're not seeing it to date with treatment for lupus, or is that a potential? Because it didn't show up for many years after the patients were treated.
Yeah, that's a great question. Again, there are potential risks, toxicities with CAR Ts, and as you mentioned, in the oncology products, there are key black box warnings about various risks. You might have seen in the news, the FDA is investigating a small handful of T-cell related malignancies that might be due to the CAR T products or the process involved in generating these. So far, the experience has been cautiously, I would say, optimistic in the autoimmune space. But again, we certainly in the formal clinical trial setting, we want to closely monitor patients for any potential, side effects, toxicities, and monitor a variety of things: their blood counts, the recovery of their blood counts, those sort of things. So, again, so far the early experience from Professor Shett and his team suggests that CAR T may be reasonably well tolerated in lupus patients. These patients, again, generally have better or more healthy bone marrows, if you will, compared to oncology lymphoma patients that have been through lots of chemotherapy, other interventions. But again, it's an early experience, and close safety monitoring will be part of these efforts and advancing this therapeutic platform.
For phase 1, do you have to go or get off all of your medication?
Yeah, so as Dr. Reif touched on, there is a washout of some background medication. Our particular study, we do allow maintaining a low dose of prednisone. Also, the reason why we have that washout also is to ensure that the T cells that are collected from these patients are good quality to produce the final CAR T product. So again, that's the reason why we have that washout. We may loosen some of those rules as we gain more experience. Also, though, Professor Shett and his team, they had a pretty strict washout of background medications, and from again 8 patients and counting experience, they have related that those patients did reasonably well. They didn't have any major flares, and again, with advances in the manufacturing, that turnaround time is reasonably manageable, that, 3 weeks or so, patients can be, closely monitored until they get the CAR T, the lymphodepletion conditioning and CAR T therapy. Yeah.
Did you have a question?
Hello, doctor.
Mhm.
I know that the
Oh.
bodies are.
Yeah. That's, okay. Yeah. Sorry.
Oh,
Yeah.
sorry.
Yeah.
So your body's always producing B cells,
Mm.
and I assume in a lupus patient, somehow they have those same autoimmune tendencies.
Mhm.
In this case, how is the CAR T treatment
Mhm.
clearing? You said resetting the system. How does it
Yeah.
do that?
Well, yeah. So fundamentally, I think there's a lot of points behind the why that will still be sorted out for a period of time. Also, as Dr. Wallace touched on, there's a number of other points of immune dysregulation in SLE. So, we haven't really sorted out exactly why this type of deep B cell depletion produces such profound results. But it has really turned us back to the idea that maybe it is the B cell all along, but we needed a platform like CAR T that could lead to a deep, complete ablation of B cells, wiping out all the B cells, including in tissues like the kidneys and skin where the inflammation is. Yeah, so again, we don't really have a clear answer on the why of the immunologic reset, but there'll be ongoing translational and other efforts to try to ferret that out. Mhm.
Yeah, so I know that we've been focusing on SLE for this, but there was a reference on one of the slides that may be unrelated, but I just wanted to ask. On slide 15, there is a reference that more data on efficacy will be available for systemic sclerosis and myositis.
Yeah.
Is this something that you can talk about?
Yeah, absolutely. So this group in Germany, Professor Georg Schett and his team, they basically have a compassionate use program, and they have now dosed patients with idiopathic inflammatory myopathy, basically anti-synthetase syndrome, which is a subgroup of dermatomyositis, and also systemic sclerosis patients. So that's on this slide here. They've published actually just 2 weeks ago in the New England Journal of Medicine, 15 patient experience. 8 of those patients were SLE. 3 were the idiopathic inflammatory myopathy, and 4 systemic sclerosis patients. And basically showing maybe not to the exact degree of transformational results, but definitely showing dramatic cessation of active inflammation in these other disease states. And definitely there's a number of other B cell driven autoimmune diseases. So the excitement, even beyond SLE, is that this type of approach could have broad applicability.
Thank you.
Mm.
One over here.
Anybody else?
Yeah.
Hi, great presentation. I had a question about, okay, I understand that the research that you all have for the T cell, the T CAR cell production. Do you know when, or maybe you might not know, but how would one with lupus get that information when it is presented so that we could be part of the study?
Yeah, so I mean, certainly, we want to try to get the news out about active trials going on for, not only our study, but just again the general community. As I mentioned, it has become a very competitive space with a lot of companies with different, CAR T products. Again, nothing is commercially approved in SLE. As I mentioned, in oncology, there are a handful of commercially approved CAR T products for certain lymphoma patients and other, B cell cancer settings. Yeah, but, again, I think, advocacy groups like Lupus LA, other groups are trying to get the word out about the status, not only the research, where things are on the pipeline, and, again, trying to make sure that patients are empowered and informed about, the status. And then, professional meetings, the rheumatology groups like at ACR, EULAR, much of this evolving data will be presented, published there, and likely, carried over in the general news and medical news areas.
is there any, is there like a website or anything like that that it will be presented to? And just in case we might miss it, in social media or in the news or anything like that, that might get skipped over or whatever, that maybe we can go to or whatever that's kind of specific that's entailed for that particular procedure that you guys are wanting to experience?
Yeah, and I mean, I think we are like Lupus LA has a website that lists some of the active clinical trials. There are actually a number of I guess you'd call influencers who are very vocal. Key opinion leader rheumatologists and other specialty physicians that are very good at sort of compiling a lot of this data, presenting. There's a Rheumatology Now is a website that is run by Jack Cush, who's a seasoned rheumatologist and has a lot of educational updates and research updates on status of various trials and efforts as well. And again, I think some of the folks at Lupus LA may be able to direct you as well to some of the other platforms where you can get some of this information as it comes out.
Dr.
Okay,
Patel,
thank
let
you.
me ask you, do you want to offer share the Impact Bio website? So that if
Yes.
anybody wants to learn about your particular study, I mean, not everybody qualifies, but might be
Right.
good to share that out.
Yeah, absolutely. Yeah, so we do have again this active phase 1 or study that's undergoing active recruitment in the phase 1 part. Again, we've already activated UCLA. There's a QR code that is with our table and literature that you can scan, and will take you to our website that has some other information about our study as well. So, yeah, thanks. Okay, thanks everyone, and we can enjoy a quick coffee break.
Thank you all for staying. I'm excited for you to meet Liz, Vanya, and Cambria. They are 3 of the 7 members of our new patient advocacy panel. This group was created this year to amplify the patient voice within our community and our organization. Ladies, thank you for being here.
Thank you for having us. You guys, you're here. You are the you're the winners. It's so nice to see everybody. My name is Liz Morasso. I see a lot of familiar faces in the group, so that's always nice to see. And Lupus LA and just our panel really thanks you guys for being here, finding out more information, but also just connecting with each other, because that's what it's about, right? How's the day been so far? Good. Nice. So this panel is the patient advocacy panel. So we're going to be talking about some of our experiences, things that we've gotten our stories out to the community, what that looks like in sharing that, but also what that gives staff, because I think you'll see that that's probably a theme for all 3 of us. And we will welcome questions and thoughts at the end, and maybe a brainstorm too around some ideas of what we can do as a community to support each other, and also as panel members, what we can do to help advocate for you guys as well in our work. So I really look forward to those conversations. So joining me today on this panel are 2 remarkable individuals. Cannot speak more highly of them. Vanya, I've known for close to 15 years. Cambria, I've known for maybe 6 months, and they both are so special I can barely take it. So Vanya is an infant specialist living with systemic lupus since she was 10. My name is Liz. I'm a psychotherapist and lupus patient. And I'll let both Vanya and Cambria talk about their experiences, but I was diagnosed at 16 with lupus RA, and I felt like if I could not, me and my family could not navigate the push what button. Oh, I had no idea. I don't know if I even need this. So I felt that, if me and my family were having a hard time navigating my diagnosis and navigating the medical system, that there must be
so many other patients and families that are experiencing the same. So I became a medical social worker and then went into private practice, eventually working with oncology patients, but also patients with other chronic and acute medical conditions, many of whom have lupus and rheumatoid arthritis and other autoimmune diseases. Cambria is a model, actress, and a disability justice advocate. So I am definitely surrounded by incredible, strong women. And both Cambria and Vanya, and I think I can speak for myself too, we just have a unique story about resilience and insight and growth that have really shaped our journeys, but in telling our story, hopefully have also helped others in our community. So that's what we're going to be talking about today. Any journey with lupus is really personal, yet the shared experiences within our community, I think we all agree, just have a really profound impact to uplift and inspire each other. And you guys are probably already experiencing that in the conference right now, surrounded by our community. So it's telling our stories that we find common ground, understanding, an incredible sense of belonging and validation. And I just wanted to give a shout out to anyone who has been to our support groups in the past, which is how I know many of you. And also to those who haven't come to a support group. Lupus LA has both virtual and in-person support groups that are really a testament. Yay! I see you, Jackie. I see you. Where that I think are really a testament to this. And I've facilitated many of these groups. And as both a facilitator and lupus patient, I've just gotten so much out of this and those experiences. These are spaces where our stories weave together and they foster such a beautiful community that's both healing and empowering. So today we're here to share how authentic storytelling and community connection and advocacy have been sources of validation and strength for us and people in our lives, along with our lupus journeys. And we're going to share how our stories have helped to build up others. And I think, I hope both of you guys agree that it's also helped to build ourselves up as well in sharing our experience and hearing the experiences of others. Awesome. Let's dive in. We good? We ready? Cool. Awesome. All right. So I'm going to start with Vanya here. Is there anything that I did not mention in my description of who you are?
Not really. I am 29. I've been living with, like she said, with systemic lupus since I was 10 years old. I was diagnosed pretty quickly after my 10th birthday. I was experiencing some chronic pain all over my body, and I was dismissed a lot by pediatric doctors telling me that I was just lazy, I'm a preteen, and that I just wanted to get out of school. My mom knew that, yeah, I did fake the cold and sniffles once in a while, but this was something, I stopped playing with Barbies and stuff and stopped enjoying movies. So she's like, no, something's very wrong here. She's not that great of an actress. So once we kept seeing the doctors, they just kept saying, oh, it's growing pain. Oh, it's this. Oh, it's that. It's nothing. It wasn't until my mom pushed to see an elderly doctor that just sees elderly patients. And he promised to see us after hours. So it wasn't even on the books. He kind of felt my joints and kind of felt around my body. And he said, oh, these doctors are so stupid. He said, it's lupus. So my mom said, can I have medicine for that? Can we get a prescription and go home? And he's like, oh, no. You don't know what you got into. So he gave us a referral to Children's. Once I was at Children's Hospital, where I met Dr. Rife, he put me in a lot of steroids, gave me a lot of fluids, just a bunch of medicine to deal with the lupus. The lupus was reacting very well at that point, and we were set to go home after a week of staying there. The lupus got very mad that it was getting under control. And it left me with a horrendous seizure. That seizure left me in a coma. I was in a coma for a week. When I woke up from that coma, the doctor asked me, do you know who this lady is to your side? I said, no, she was my mother. I had completely wiped my memory. At 10 years old, I had to relearn how to talk, how to walk, and on top of that, learn what my name was. And the reason I didn't remember anything was because of lupus. I stayed there for 2 months, relearning everything and trying to rehabilitate my body. From then, I just pushed and pushed harder. Dr. Reif said, "You're going to be my little star. You're going to push. You're going to fight through this. You don't know what you've been through." And I told him, "You're crazy." And
Shout out to Dr. Reif.
After many, many years of being seen with Dr. Reif, he did one time come up to me and said, "We have this ball and I want you to speak and tell your story. It's powerful." And I said, "No, I don't want anyone to know that I have lupus. Like, that's the last thing I want to be associated with, the sick person." And he said, "No, you can really use this to empower others. And they can learn that what it means to actually live with lupus." So since then, I've been using this story to really empower and just educate people that lupus is not just for older patients and middle-aged patients, but children as well. And arthritis is not just for the elderly, that anyone at any age can get lupus. And to bring you to now, I'm now 29, like I said. I work with infants with autism, and I work at their house to rehabilitate and help them through their needs. So thank you all very much.
Tanya's a superstar, obviously. We love her. Amber, is there anything that I missed in your story that you'd like to share or feel like it's important for people to know?
I am about to be 35, and I was diagnosed when I was about 16, 17. I woke up one night after having a really hard day at school, and I was having really bad abdominal pain. Lupus runs in my family. My aunt passed from it. My grandfather had it, cousins, and then I found out on my father's side, cousins had it as well. So my mom always knew that there was a potential for it to continue in our family. And so when I started having abdominal pain, she brought me to the ER, and they kept telling me, "Oh, everything's fine. It's just ovarian cysts. So your ovarian cysts burst and you'll be fine." But everything just
I like how
started.
they're saying just.
It's just female problems. That's the big thing. They love to go there. But I kept having to come back. So over the course of 30 days, I just had ER visit after ER visit. And my mom was like, "Well, I'm looking at her chart and her white blood cell count is consistently low. My sister has lupus, so can we get her a lupus panel?" Doctors immediately told her, "Oh, no, it's fine. She'll be fine." Lupus panel. I didn't have all of the markers to begin with, but I had enough for my mom to be like, "Okay, we need to see a rheumatologist and we need to keep an eye on this." Lupus ended up being a sister condition to, I also have CRPS, which is also known as the suicide disease because it's technically the most painful disease there is. And
Can you tell us what that stands for?
oh, sorry, I just got diagnosed with it.
Sorry to
but-
put you on the spot. That's what I do best.
Any doctors in here who know that one and want to help me out? But that's the one. Thank you. I knew it was
Thank you.
chronic regional pain syndrome.
Chronic regional pain syndrome.
It used to be called something else that started just with an R, but then they changed it to that. Thank you. Yes. And so having both of those conditions, which are both at that time, not something that doctors were trained to notice or to identify, I got a lot of, "Oh, she's just drug seeking. She's not really in pain. Send her home." Being called a drug addict at 17 by the doctor to my face. And it just instilled in me this anger as a teenager because I felt like the whole rest of my life, people have been trying to protect me, and you're a kid and we're going to listen to you and come to us if you ever need anything. And then I come and all of the adults are telling me, "Oh, you're you're exaggerating." Or my favorite was, "It can't hurt that bad." Like, have you ever been told it can't hurt that bad? Let me kick you and tell you it can't hurt that bad.
I see way too many nods, you guys.
It's ridiculous. And so I learned as I got older, I got to about 18, 19 and decided, you know what, I need to learn how to take care of myself. I'm college age now. I need to go out into the world and not be reliant on my mother my whole life. And so I took a year off before I went to school, and I moved out to LA and I tried to live my life. Seizures, hospital visits, being called, like ambulances coming to clubs to come get me. It just became out of control to where I was like, okay, I need some help. I need a doctor who's going to be able to manage all of the symptoms at once. And it took another 6 years to find a doctor who heard me, who, when I would lay out all of the things I'd been through, all the medicines I'd been on, who didn't say, oh, you're just a hypochondriac. It's not that bad. And so I was 23. I was trying to finish college. I attempted college twice. The first time I kept having seizures at school, and the school figured out that I had a more rare disease and they wanted to identify what was wrong before I had the CRPS diagnosis. So they kept sending me to their doctors at Berkeley. And so I kept missing classes, but I was able to still do well. So that caused a problem with my college. And because I was sick and they didn't understand how I was getting good grades, they accused me of cheating. And they did it in a way where I couldn't prove that I didn't cheat. So I had to leave school. And it felt like they were using my disability against me, that they were trying to profit off of it. And then on top of that, kicked me out of school for cheating when I've never cheated in my life. So I left school, went home, ended up continuously having seizures just due to stress, and was also in a coma. I was in a coma for about 5 days, in the hospital altogether for about 2 weeks. And I just remember when I woke up from the coma, my brain woke up before my body did. So I'm intubated, I'm strapped to the bed, and my brain is wide awake, but I don't know what happened to me. So I think I'm paralyzed and I'm freaking out. But there's a set of trauma that you go through from going through an ICU experience that I had to learn was going to play into the stress of my lupus when I left that situation. So I got better, I left the hospital, and my lupus just spiraled from the stress of having been in the ICU, the stress of having gone through the trauma of almost dying and having to relive that process and remember all of it, because you don't remember anything when you come out of a coma. I decided at that point that people didn't understand, society didn't understand. And I had just started modeling when I went into my coma. And I said, you know what? I'm going to use my platform. I'm going to use modeling as an outlet and as a way to educate people, because people, I hate to say it this way, but general population doesn't care. If it doesn't affect them, I found that a lot of people are averse to talking about disease and illness because there's a fear of death. There's a fear of the unknown. So people do not educate themselves until it affects them. And I wanted to give them a way of getting educated that was entertaining, that was unexpected, that was something that they were going to be able to look at me with my cane and say, okay, I don't see that in my everyday life, but I have already preconceived notions about who you are as a person. So let me educate myself because I'm invested now. This is an influencer I love your clothes. And it just started to trickle in more and more opportunities. More people started to connect with me and say, hey, I have lupus too. Hey, I was diagnosed at this age, or hey, I use a cane. The amount of 17, 14, 12-year-olds that message me, I see you and I have a cane too. And people tell me I shouldn't have my cane. I'm too young to use my cane. That's why I do it. Like, I never wanted to be a model. I was an English and psychology major. I don't like being up on platforms, but I realized that if I don't do it, who will? Thank you.
I told you they were amazing, right? I mean, both of you guys really touched upon what came next after the trauma and what came next after these really challenging parts of your life. And both of you guys mentioned some kind of advocacy or, some kind of storytelling or, sharing your experience with other people, whether they were comfortable or not. And I love that you mentioned that, Cambria, of like, I'm sorry I'm making you uncomfortable, but sorry, not sorry. And I'm just wondering how, and Vanya, maybe we'll start with you. Like, how was sharing your personal story? You mentioned the Orange Ball, which was a Lupus LA gala. And I'm just wondering how sharing your experience there and then through the years continuing to do that, how do you think that's helped other patients and people that you've spoken to?
I definitely feel like it's helped in the big notion of validation. A lot of people, and I experienced this as well before getting diagnosed, I didn't have in my close circle other people who even knew what lupus was or experienced it personally. So finally having someone say, oh yeah, me too. I feel that too, that fatigue, that pain, that, oh, annoyance of having to always call off of work or school for doctor visits, all of that. The pharmacist knowing you by your first name because you're always there, that kind of thing is like, me too. And I didn't get that with my friends, with my coworkers, with my teachers, with anybody. And that meant a lot. Also just through my pain, doing something positive with it was so important. Okay, this was my story. What can I do with it to do something positive with it? It's hard to talk about it and it's traumatic what my family and I went through, but what's something that good could come of this? If it helps some other one feel not alone, if it helps somebody do some more research on it, or for other people to want to acknowledge that this is real, because some people don't even think we're really sick, then it's all worth it putting all my stuff out there.
It sounds like you were able to use your anger to do something, which is how we process anger. That's the purpose of anger, is to give us energy to process that feeling.
Yes, absolutely.
Yeah, I love that. Cambria, how about you? And it sounds like a lot of what you're doing, and Vanya too, is on social media, which I know you have an amazing presence on. And so whether it's through social media or any of the other opportunities you've had to speak with other patients, not just lupus, I mean, you could speak to any, how do you think that telling your story has helped them?
I think in two specific ways. I second what Vanya said about having that mirrored experience. And I also think for a lot of us, there's so many side effects that sometimes we don't know what to attribute to what, or what's real, or what's like just our bodies. So being able to bounce that off of people who actually experience it, who be like for the longest time, I didn't understand that my fatigue was caused by this. And I just felt lazy, and I felt like I couldn't do anything for myself. And it was everybody else's outside opinion telling me, oh, you're just not applying yourself. And I had to realize, no, this comes with it. This is an actual impairment. I think for me, that one of the biggest things that stood out to me was once I put myself out there on my platform and started making disability content, especially with my cane, because for a long time I wouldn't show my cane. I used my cane, but I was embarrassed. My internalized ableism, whoo, that thing was strong. And so I spent years putting my body through even more pain through modeling and runway, not using my cane, rather than saying, you know what, this is who I am and take me as I am. And I finally started getting people message me. And there was this one woman, Jessica, I will always remember her. She was just lost. She was going through the very beginning stages of figuring out that something was wrong. She was getting her blood work saying, oh, this is wrong, or this is positive, or this is negative. And she didn't understand any of it. One of the things we all started going through is we have to understand insurance. We have to understand blood work. We have to understand what the doctors are saying. That's a lot that the average lay person they don't learn that information on a daily basis. So for me to be able to, one, simplify things for her, tell her where to go, who to go to, and then just event and let her talk to me about the fears, the cycle that we go through of, oh my God, do I have cancer? Because that's a big thing a lot of us jump through first. I didn't realize the impact I was making on her until she got diagnosed with a connective tissue disease, and then came back into my life and was just like, the moment she saw me, she just jumped me because she couldn't imagine if she had had to go through that without the information that I was able to provide for her. And it's me wanting to do for other people that I didn't get done for me, you know?
I think too, Cambria, you mentioned something so important, which is what other people get to have because of what you and Vanya are sharing that I think all three of us have combined that we didn't get. So support people around us that already knew or had baseline information about what lupus is. I remember when I was first diagnosed with lupus, I was in high school, and there was such a learning curve for the people that I was in school with, because I remember there was a guy that was so hot and he did not want to go anywhere near me because he thought it was contagious. So, I mean, my sassiness is contagious, but my lupus is not. But I love that you guys identified a need based on your experience and really, helped other people, but also felt that yourself through those connections that you guys were making. I love that. I primarily use my story professionally, and that's what works best for me. So I was a loud person before my diagnosis. I am a louder person after my diagnosis. Hello, steroids. And those that know me can attest. So I really felt like in order to get my energy out, in order to get that anger out, in order to get those feelings out, that I had to do something, because that energy was not going to do well just staying in my body. And so me going into a master's level education and becoming a medical social worker, getting involved with Lupus LA and other organizations that at the time were doing our families living with rheumatic diseases support group at Children's Hospital. That was not only a professional experience, but I was really able to, one, connect with myself and my inner child and inner teen that did not get that support, be validated by those around me, even though it was a professional setting, but also offer support that was both from personal experience, but also professional training that I felt like was really important and provided a unique perspective on providing support that I so wish I had. And Vanya was a member of that group. And so then to see Vanya on stage is amazing because it created future leaders too. And I'm also wondering how Cambria, how were you personally helped by a patient sharing their story? It sounds like you made such an amazing connection with the one person. But let's talk about how it's helped us.
So I said I went to college twice. The first college I went to was Mills College in Oakland. It was an all-women's college. And that was probably the height of my lupus flares. And I met a woman there who I now call my big sister. And even though we had different issues, she recognized the struggle that I was dealing with. So she had, I'm having a really rough morning today, so words just do not want to come.
Good
Red blood
company.
cells. Exactly. I'm like, I know the empathy
We're
there.
good.
I feel it. The disease with red blood cells that mainly affects African Americans.
Sickle cell?
Thank you. That's the one. Yes. So she had sickle cell, and that's a struggle. I don't know if I'd switch ever, but her seeing what I was going through, her seeing the obstacles that I was going through, and being willing to just open up and sit down with me and share her story and be like, sis, you can do this. She's like, you're not the only one. We are all dealing with something, but it's how you deal with it. It's how you go about it, and showing me the steps. Not by that point, my aunt had passed away, so I didn't have anyone to go through, and she'd never gone to college. So I had no one in my position taking on the tasks that I was trying to take on. And so just having this woman in my life who had empathy for me and love for me, and who was like, I understand the pain. Someone who actually believed that I was in pain was huge to me.
I even noticed too, sometimes in sharing stories with people who have similar experiences, doesn't necessarily have to be lupus, but it can be connecting with someone that has another condition that also has similar symptomology to it, is we can use language like tired. And that person knows what we're talking about, right? If we're talking to somebody that has lupus and we say, oh my gosh, we are so tired, that person knows that it's not tired and go for a nap and you feel really rejuvenated after and ready to party. Versus telling someone, whether they're in the lupus community or a community for another condition, when we say tired, I know exactly that feeling because there isn't really language for that, right? Like there isn't really great language, fatigue-ish, maybe.
People are like, well,
Yeah. So just that feeling of knowing someone gets what this language means and gets what this feels like in my body.
Or forgiving you for not making your commitments. That's a big one for me because I was an overachiever before I got sick. So the idea of not doing what I said I was going to do or not accomplishing what I said I was going to accomplish, I would tear myself up worse than anybody else could. And I had to give myself grace. And I learned that from other people telling me, you're being too hard on yourself. Like, I have this condition going on. I have this going on. Sometimes life happens. I am going to say, I think after COVID, a lot more people get that now. And I'm never going to say COVID was a blessing, but I do think that there has been a societal shift in a lot of people's mindsets because now you have to understand a little bit better. But yeah, it's a rough thing.
Hear that. Hear that. Thanks for sharing that. Can't write that. Yeah. Vanya, I'm gonna ask you the same question. Like, how do you think you sharing and being open about your diagnosis affects or impacts others? What have you seen?
I feel like I've seen, at least in my life, it has given others the ability or the power to also share their story. So I've had, just with the support group that I help with at Lupus LA virtually, I've seen a lot of young adults bring up the topic of not knowing to share their lupus with maybe a partner. A lot of females feel like it's not really cute to be sick if you're just meeting a new guy or how to talk about that. So even stuff like that, bringing up these topics, they usually would say, nope, it's a definitely 100%, don't bring it up to him. And now these topics are available to be discussed and talked about because they see other patients like me who have gone through it and I'm still alive, I'm still able to date and live with lupus. Oh, you can go to school and have a career now? Oh, I didn't even think that was possible. So these topics are coming up. Oh, you want children one day? Oh, I didn't even think I was gonna even touch that topic. And now they're starting to think, all right, if I see someone else who's literally been through what I've been through and come out of it okay, maybe I can start thinking I can live a quote unquote normal life as well.
And it sounds like both of you are having one-on-one interactions with people, but also through social media or through the support groups, through other avenues that you're also having effects on groups or, you know, a lot of people at one time, which is also building community for them as well. So I love that piece. I think when I think of this question, how it's impacted others, I just think of how many hugs I got today from people who have been in my support groups or who I knew from either Children's Hospital or UCLA, which are facilities that I've worked in. And that is what really sticks with me because they don't have to say anything. Their body language, their hugs, them remembering my name as someone who helped support them or shared my journey and shared my vulnerabilities with them. That really sticks with me more than anything. So I think I had a different answer before all the amazing hugs I got today. So thank you all for that. So our next question is, and I'll start with you, Vanya. How were you personally helped by a patient telling their story?
Yeah, I would say I was definitely helped. At first I was very not able to approach the concept of support groups. Since I was so young, again, I didn't want to be associated with being sick or lupus at all. My mom dragged me to these support groups at Children's Hospital.
The truth comes
literally,
out.
like promising me a cookie or something afterwards or whatever. But, or no, it was the gift shop. I could get something from the gift shop.
That is a good gift shop.
I would end up coming out laughing and not wanting to leave because I made friends and we were me and the girls there at the support group, we always had this thing of naming the cute doctor and stuff like that. So we just, stuff I couldn't talk about with my girlfriends at school, I could talk about with these group of girls. And to this day, I still keep in contact with a lot of them, and they're now married or have this career, having this going on. And it's just a community and support system that you literally don't see them all the time, but they stay with you for life.
I did not hear the discussions about hot doctors when I was facilitating
Oh,
that.
we
group.
waited till you left.
Oh, okay. All right. I'm learning so much here. Cambria, same. How were you helped by a patient, whether it was lupus or not, or another condition, sharing their story with you?
A lot of different ways. Sorry, my mind just went blank. Can you say that one more time?
Yeah. How were you helped by someone else sharing their story with you, whether it was lupus or another condition, especially because you really do, your socials and what I see you on and your advocacy is tailored to so many different groups.
For me, I think the biggest thing was helping me to challenge my internalized ableism. I used to be
Sorry to interrupt you, Cambria. Can you talk a little bit or tell the group a little bit about what internalized ableism is?
So ableism is basically a fear of disease. It's how you act when it comes to someone being sick, how you act when it comes to your view of being sick. It's this automatic negative view of it. It's less than. And so for me, the idea, like you said, of being sick was, oh no, that needs to be the farthest thing from me. I can't be viewed as weak. And that was a huge thing for me as a Black woman, especially being strong is a big thing in our community. So I needed to be the strong one. I needed to fight this and not let anyone see my weakness. But what I realized was that was the weaker choice for me. That was the choice to placate other people's feelings instead of centering my own. And when I started to be around other people who had other diseases, who had other chronic illnesses, and they were telling me, you know, I live in this. I don't make apologies for it. That was my biggest thing, is always saying I'm sorry. I would have a seizure and I'd apologize to the people around me for it. And it's like, no, I had to learn to be proud of my existence and to stop thinking that I was not normal. And meeting other people and seeing, okay, this is normal. This is a normal, diverse part of being human. This is a part of human existence. It helped me to say, you know what, I'm going to use my cane in my shoots and you're going to accept it. I'm going to talk about the fact that today I have a lupus rash on my face and I'm going to explain it to you. It allowed me to stop hiding. And I spent many, many, many years hiding.
Yeah. And it sounds like one thing that was really helpful for you was getting the normalization from other patients that helped you maybe end them to more positively impact and question and challenge potential ableism in their lives that is not being challenged by people that do not have some kind of health condition or disability.
Even just understanding how some of the normal things that people think are helpful, that you tell people push past it, or, oh, you know, if you're tired, go for a walk, or the little tidbits that people give you that are supposed to be helpful. I had to learn from other people, no, that for a disabled person, that can be a microaggression. I had to learn, like, why did that feel similar? Why did that feel like something I could identify, but it's supposed to be helpful? So those are all things that I learned from having interactions with other people with chronic illnesses and them saying, no, sis, you don't have to take that.
Absolutely. And I don't know if you guys both agree, but I think disability is often not talked about as much of the other isms. So we'll talk about racism, we'll talk about homophobia, sexism, and disability is often out of those conversations. I see a lot of nods. And
Point where people will tell you, you're not disabled. Don't
Right.
talk about that.
Yeah.
Like, I've had my cane in my hand and people are like, you're not disabled because I'm young, I'm beautiful. It's like, that doesn't discount anything. I'm like, listen to the connotation that you're using. If I'm to this to be disabled, what does that mean?
Amazing point. Yeah. So lastly, I know that Vanya, you have been to Lupus LA support groups. Kimberly, you have not.
think I did a virtual one once.
Okay, cool, cool. That's enough. That's okay. And so just, I wanted to get you guys' thoughts on support groups in general, and whether it's a formal support group or even patients coming together, what your thoughts are on the role that support groups can play, and community too, just the role that community can play. And I say this with a little bias as someone who has facilitated lupus support groups for 13 plus years. So I'm a little biased on this. And just really encouraging all of you to check out Lupus LA's support groups because they are a beautiful place for community. But I'd love to hear what you guys' individuals' thoughts are or experiences on support groups is. Vanya, do you want to go first?
Sure. So the one that I've definitely helped with virtually, which is the young adult support group. We meet every every third Tuesday. I would definitely say it has helped a lot, not just as someone who's not already been through it, but has already 19 years of experience versus someone who's just been newly diagnosed. I can be a platform to help them with advice or sympathy or just tricks and whatnot to help them with their pain or what they're feeling or recommendations for a doctor. But I also feel like it helps to hear their stories and what they're going through. Kind of reminds me sometimes what I take for granted, what I have been through, and kind of mellows me down of, oh yeah, I used to experience that too, and look how far I've come now and don't experience that. And that definitely helps. And even the support I got as a kid, I feel like it feels good to give back to them and kind of repay that forward. I would say like 90% of people that come to our support groups come back. There are those that just kind of trickle in once in a while. But I will also say that we don't always just talk about lupus. A lot of times we're talking about, oh, this one coworker and oh, this and oh, you know what my husband told me and stuff like that. So we are normal and we are talking about everyday life stuff and it's very not formal. We are in our jammies, we're in our rows with our hair up and with a tired face. Some of us don't even put the camera on because it's scary to put it on. And we just talk about whatever, or you just listen in if that evening you just want to listen to what people are going through. You can even type in the chat if you have a recommendation. Oh, you should go here, or oh, you should try this. I heard this smoothie was good, or whatever it is. So it's very informal, and I would say you get a lot out of it.
I love that. Vanya, are there certain things that you would say to people here that maybe haven't been to a support group before?
I would say it's just like everyone, it is scary at first. A lot of people get anxious of putting all their problems out there, or their pain out there. I would say definitely virtual groups. They're more at your control. So you don't have to go inside of a building and check in and look weird or feel odd if you're walking out when no one else is leaving. This is in your comfortable space at your house. Like I said, in your jammies if you want. No one is judging you there. And you come as little or as much as you want, and we're all welcoming. We're all laughing at each other and poking fun at each other. And it's honestly a group of people that, male and female, that you can connect with.
I love that. Kimberly, how about you and your experience?
For me, I was averse to support groups for a very long time. It's not that I didn't think that they were helpful. It's not that I didn't think they were a good thing. I felt like my condition already took over all of my life. So to me, it felt like just going to another doctor's office. And before there were video opportunities, it was inaccessible. I don't drive. So I was like, okay, that's just not going to happen for me. I'll find support groups other places. And I did. So all of my support groups were over the internet. I found lupus support groups. I found other outlets. And like we said, it's just really about understanding that you're not alone. for me, I think the best part was being able to talk to people about medicine and, oh, well, my doctor said this about this medicine. And then someone say, oh, well, girl, there's this side effect. The doctor didn't think about that. You should know about this side effect. Like having that instead of having to just go through it on your own. Like for me, I was put on Lyrica for fibromyalgia and lupus when I was like 19. But the male doctor didn't think to tell me that I would rapidly gain weight. And this was when I started modeling. So it's the certain things like that to where I can bounce my ideas and the possibilities off of other people. And my doctor might not have the same priorities that I have, but someone in my group might.
That is so important that we can feel empowered by our community and accept that the medical system is not perfect. And you said it, not me, as a medical social worker that used to work at this institution.
I'll say it for you.
That you do get access to information that is better from other patients who have experiences with these things. And even if it's not something you have an experience with, that you still get to put it aside in your brain, in that certain part of our brain that retains all of the information that's meaningful for us. And it might come up one day, and it might be something that someone didn't share with you, or something that could better your experience with a medication, for example. So I love that you mentioned that. That's awesome. Yeah. So we're gonna wrap up this part of our panel, but I'm really curious about you guys' thoughts and perspectives from the audience on advocacy and telling your story, or ways that the three of us and Lupus LA can help to advocate for you, whether it's in a support group or conference or with community events, on just how do we come together? How do we tell our stories in a meaningful way? How do we hear stories in a meaningful way? And how do we start living our life in the most meaningful, connected, validated way? I know that's such a social work question that I just asked. But yeah, we'd love anybody's feedback. And I know that's a huge question too. So really any of your thoughts, would love to hear.
Susan's behind you, she's gonna give you.
Also, if you have questions about our stories and experiences as well.
As an older person who hid my lupus for a long time in the workplace and really only outed myself when I had a colleague who had a rash on her face, in a small way, I think talking about how you do that and how you, and I'm retired now, and I found in my last couple of years of work, I didn't care. And I did talk about it, but before that I didn't. And so I so admire that you navigate that now, but I still think there's that stigma that can hold your career back. I feel that I even knew a CEO once figured out I was seeing a rheumatologist because I had it on my calendar, and I don't know how that impacted my career. So I don't know, it's a whole area, but it's one area that we haven't heard a lot about today. And I wasn't the kind of patient who was close to disability, but it was a struggle.
Absolutely. Absolutely. Of course, Cameron.
I worked in a law office for about a year. My mother does workers' compensation. And when I left college and didn't graduate, I was floundering and I didn't know what I was going to do with myself. So I decided to go work in a law office with her. I didn't necessarily hide my disability, but I made sure to make it not obvious. I told my boss and I told my manager because there were certain accommodations I needed. But in response, the amount of bullying, the amount of minimization, all of a sudden now everything was an issue. And it was because not only was I getting an issue from my boss for having to ask for accommodations, I was getting issues from other coworkers because they didn't understand and they would get jealous. So I definitely, I feel you. It is not something it's something you definitely have to think about. And especially I feel like as a woman, there's a different perception when you're in a workplace as well. So for me, there was just compounding issues that made it to where I ended up in a hostile work environment. So I understand hiding it. I really do, because I went to another job afterwards and I didn't tell anyone. It made it harder too, but there's no win-win sometimes.
I operate with a megaphone out of my mouth. So I think I learned really early, especially in being diagnosed in high school, that people did need to know what my needs were to meet them. So that was scary because that meant that there was vulnerability in the answer that I was going to get or the reaction I was going to get. But I knew that if things couldn't meet my needs, that I was going to burn out really, really quick. So I continued to take that into working where I worked at Children's Hospital and UCLA, so huge institutions. Also the privilege of a lot of resources at both of those institutions around disability and Family Leave Medical Act and things like that. But I was extremely open, and that made it much easier to work in those environments because there were no surprises. That said, my last job I did rage quit after not getting accommodations that were necessary for me. So I just pivoted into private practice where I could better take care of my body and meet my own needs after preaching that for a long time. And also be able to see a community that might not otherwise have access to services. So that's how I just chose to embrace things. And if there is a workplace that wasn't going to be open to that, that they were not the right workplace for me because I was not willing to make that accommodation for them. Vanya, do you have any thoughts?
I would say definitely my personal experience, since I was young and living with it, once I entered the workplace, I took the approach of always being front and forward. And if the boss was not taking it well or thought, oh, well, she's just a slacker or whatever, she's just wanting to make an excuse for herself to not work as hard, then I would take that as a sign as that's not the place for me. I don't even want to start with that. And I already have a physically demanding job. I work with infants, so I have to be very hyper to have their attention. And I'm on the floor, I would say 99% of the time working with them because they're not at my eye level. So I have to get down on my knees and be at their level. And I have found when I was front and forward with the job that I have now, my boss wanting to work with children with autism, she's very comforting and very, you make your own schedule, work. I'm a morning person, so I work morning and by 9, don't talk to me. So this job works perfectly for me. During the pandemic, I was working at a private school with 26 children that were under the age of 3, and they told me, don't let the 3-year-olds touch each other. And I was like, how the heck am I supposed to tell a 3-year-old don't touch your friend? And from, 20 of them by myself, which is illegal, by the way, but
know your rights, know your rights, know your rights.
After that, I was like, no, this is not, they don't take my, even I think a normal person's consideration, what they're able to do and keep sane. And I moved on to a workplace that took into consideration my needs and my health, and also able to see and take that time to get to know Vanya. Vanya is a hardworking person when she does feel well. And if I say I can't, then she's being honest. She's not being lazy because you actually know who Vanya is in the workplace.
Yeah.
Hi. I would like to see if, or would like to see, like in the great world, if Lupus LA or another advocacy group could do like a series on job accommodations, FMLA, to explain to the public, like, this is what, our rights are as far as disabilities and, or like social security, disability applications process, that kind of thing, to explain, if you're considering applying for disability, if you have jobs that won't accommodate you, that kind of thing. Because I found out the hard way when I was disabled and having to go to work and ask for time off, and thinking that I was doing the right thing by giving them my off work notices that the doctor was giving me, and then told I didn't have FMLA paperwork on their end, and that I was potentially going to lose my job, and then had to fight them and HR along the way. and it only made my lupus worse, that additional stress. So, I mean, what would be awesome would be like if Lupus LA did like a series or some kind of informational thing talking about what, where the resources are for somebody to be able to find like the Jan Accommodations Network, and that the kind of things that we had to find when we went. Like, luckily I had the House Foundation support group that they had the retired judge who showed us like basically how to apply for disability, but not everybody has that. So something in a series, maybe on this, in the support or online, to show people how to go through that process, because I was really lucky to be able to have that information. But like, I see in my support groups that I'm in on like Facebook, where people are going through long COVID and they don't have those resources available, and they're running up to these walls. And I'm thinking how lucky I was back then to be able to have those resources and know that I could go to my support group and be able to talk to the retired judge. And people now don't have those resources. It would be amazing if something like that was available, to be able to go a few clicks and be able to say, hey, you know what, go to this webpage, Lupus LA has it, or, another website can have it, and you guys can follow these steps and have, all of this information available to you.
I love that. Noted, Lupus LA, noted.
Absolutely
Love it.
agree.
Yeah,
Yeah.
absolutely.
I will say, the lupus support groups that I help with virtually, we had brought up that very topic, and they actually had provided a lawyer in one of our sessions of our support group that talked to us, and we were bundling, asking all these questions to this lawyer. So another reason, definitely, if you want to check out our support groups, we cover topics just like that.
So I want to say you guys have done a wonderful job. I just love it. Lupus LA really gets this with the advocacy program, and it was pretty much a lifeline for me. And so I've been coming. It's been since we first started, meetings, and it has really come a long ways. And for anybody that is not a part of the groups, I would recommend that you do come, because like they said, we talk about so many different topics, and the thing about it, you don't have to just attend one group in your area. You can attend different groups to wherever. I mean, I attend Orange County groups, LA groups, and it's really great because a lot of your answers and fears and a lot of your questions and concerns are always I mean, they've done a great job at addressing them. So and the in-person groups were just great as well. But anyway, that's what I want to say.
Checks in the mail, Jackie. Thank you for that. Marketing, yeah. Someone back here too. There you go.
I thank you all for sharing your stories, and really everyone being here, finding a community. Like you said, when you're saying you're tired and you can't, they don't really understand. Like, it's like, oh, take a nap, or something like that. So I really glad I came today. I also want to um just concur with the young lady who was saying about talking to about medical leave and FMLA, because even when you're doing that, you get this feeling, and sometimes it's even said, well, you don't look sick. And for me, I felt guilt, so I overworked myself to overcompensate. I didn't realize I was doing that till later, but to overcompensate, which also didn't help the lupus flares and an overall being. And so my question, I have two questions. One, if you're on social media or have a following, would you mind sharing that with us? And then two, like this organization, Lupus LA, or in addition to that, what other resources have you found most valuable and supportive in your journey? Just in sharing that.
Great question. Either one of you guys want to take that?
You want to start with our social medias first, since that was our first question,
Sure.
and then go ahead.
Okay, I have a blog where I personally just blog about my day-to-day and also just stuff that I do with Lupus LA. It's on Instagram, if any of you have Instagram, it's at Lovely Lupus Warrior. And what was the other question?
We can start with
okay.
with the social medias. So for Instagram, Lovely Lupus Warrior. Cool. Cambria?
For me, my Instagram, TikTok, and I think my Facebook are all the same. It's at my first name, Cambria, Cambria, the word plus, and the word model.
Love it. My socials are all based on my psychotherapy practice. So my Instagram is just Liz, L-I-Z, my last name, MORASSO, and I also have a website for my practice that I'm working on building out some resources. My practice is relatively new, so still working on that and trying to practice some self-care in that as well. And I think your second question was, what external resources have we found, right? Yeah, so I was originally, I think like both of you guys have said, too cool for school. I was a punk rock chick in high school, so you would not catch me at anything except for that. But recognizing in my late teens that really any organization where people are speaking my values is a fantastic resource, and values being my experiences, but also just my personal values. And at the time, those were really centered around my health conditions. So I connected with LRA, which is an organization out of New York, Lupus LA when I came to Los Angeles. But I really found a lot of resources in even just talking to people at events like this. And there's many other organizations that don't do as well of a job as Lupus LA, but they do offer different information. And so using those as tangible information sources, but also just connecting with our community, you'll often find so many different resources for different issues that you're looking for support around.
For me, I think one of the main ways that I was able to get some resources was, back up a little bit. I was homeless for about a year. When the 2008 crash happened, I lost my home, and this was around the same time I was supposed to go to college. So when I got kicked out of college, I was homeless for about a year. And that was when I was signing up for disability. So the disability program is not a curse. It's very complicated, and it is specifically made for you to not succeed because they don't want you to take advantage of that program. So I had to go through a church. So a lot of churches have specific programs for people who are going through housing issues, who are going through needing financial assistance. And I was able to get put into a low income housing program through the church, who also helped me get an attorney who pro bono helped me get on disability. So there's, unfortunately, the way to do it is you have to go all this way rather than a direct route. Because if you try and do a direct route for like disability, for Social Security, you're going to get denied. They deny you right off the bat. It's their favorite thing to do. But I completely second, third, and fourth the idea of having those resources readily available, because it is a lot to search, and not everybody is going to go through disability. Lupus is not going to be a disabling event for everyone, but for those of us that it is, it should be something that we can readily get available to us.
There's a really amazing organization that I wanted to share that's here in LA that does help with insurance challenges, primarily government-based insurance. They're called Maternal and Child Health Access. I know it sounds counter to what we're looking for, but they're fantastic at navigating really challenging issues with health insurance, with Medicare, with Cover California, and other legal resources. And they have a really excellent knowledge of just what's in our community.
Yeah, or you can also just call Lupus LA too. I'm
yeah.
happy to also direct to some other community organizations, and we're happy to help.
Give Maggie a call.
Give Maggie a call.
So I think we're running kind of low on time, if not way over.
We're gonna do the raffle, if you guys
Cool.
ladies want to participate.
Sure. And if anybody's question wasn't answered, and you want to catch us outside, feel free to come on over and say hi, and get our information and let us know how we can support you. Great.
Okay, raffle time. Get your tickets ready.